So, Hanji, very good evening, everybody. Good evening. And let us now start the party with the next part of radiology. So, what we have done so far, I will give you the idea what we have done so far, and then I will tell you what is my plan for today and how will we proceed here onwards. Let us see the plan for today. So far in our classes, this is what we have done. Okay. So far in our class, we have done the CT scan, MRI, neuroimaging. Okay, this was the first part that we covered in the class. Then we spent a lot of time on chest x-ray and orthopedic imaging. Okay, so we did the chest x-ray and orthopedic imaging. And thereafter I started with the surgical aspect of radiology. When I say surgical aspect, I mean to say these subtopics: ultrasound, Doppler, IVP, Barium, CT abdomen, mammography, PET scan, and even the nuclear scans like thyroid scan, etc., which we will look at tomorrow. So what we have already done is we have done this, 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 we have done this. My target for today are, I want to teach you how to look at barium images. What are the common images asked in the exam? I want to show you some examples of pathologies on CT abdomen along with normal anatomy, and I will also show you mammography. Okay. Okay. And I will start with PET scan today. These are my goals for today. So that tomorrow I will look at nuclear scans, radiotherapy, radiation physics. So tomorrow I want to look at the radiation physics part, radiotherapy part, which is less important, but sometimes you get one question out of it. So we'll cover those in a crisp class tomorrow. That is my target for tomorrow. Okay, everybody understands? So these are my plans, and this is what we have done so far. If ever you have a doubt what is more important in radiology, always go with the sequence of the class. The class has been designed in a sequence where it goes in the sequence of importance. I have covered the more important topics in the beginning, like brain, chest, bone. Then I am coming to GIT, and I am trying to give you the sequence of importance of radiology topics as well. Okay, everybody, are you able to follow me? Okay. And we will also, tomorrow is going to be the last class, so I would want again your support. Just like yesterday, you gave me good support yesterday, so I want good support today also. We will be able to cover the ground. Tomorrow we will be able to finish radiology. Everybody clear? I have prepared the quiz also, and we missed out on some questions yesterday in the quiz, so I will cover those also today. In the end of the class, I will have another quiz, just like every day we do, so that we are all on the same page of preparation. Okay. Now, before we start, I want to start with a positive note, and this note is, sometimes you will feel tired, sometimes you will feel lost. है ना, ये होगा जिंदगी में. कई बार ऐसा होगा कि आप थक गए होगे और कई बार लगेगा कि हार गए. There will be times where you feel tired, where you feel lost. These are the times where you need to introspect and look for your purpose or look for your why. The why is that why you started. I want you all to look back and think कि वो क्या वो why था, वो ऐसी क्या चीज थी जिस कारण से आपने शुरू किया था. Why did you start this journey? Okay, यहाँ पे क्यों आए थे? Anybody? Now when you think of that why, now this why, if you keep reminding yourself, it will help you to propel forward when you are tired. Everybody follows? जब थक गए तो अगर why होगा तो वापस आ पाएंगे. Okay, and I can see already there are different requests by students regarding when to take a break, when not to take a break. We will see as per the democratic method and see how different students are responding, and at that time we will decide. But always keep reminding yourself कि मैं यहाँ तक क्यों आया था. And also I just wanted to mention today, it is a very important thing, and I think it is going to help you to go forward here onwards, is the attitude of gratitude. Now what does this mean? Now it is a very powerful line and a very powerful thought, that a person was complaining about, okay, I want you to listen to my line. A person was complaining about bad shoes. Somebody was complaining about bad shoes until he saw someone with no leg. Okay, so it is important to be grateful for what you have, and I just want you to just close your eyes and understand that around 20 lakh students appear for pre-medical tests. Out of this, roughly 1 lakh, less than 1 lakh will become doctors. You are already on this zone, so you are already living a life that many and I would say millions of students in school are dreaming to become you. ओके, आर यू एबल टू अंडरस्टैंड कि आप बहुत सारे लोग सपना देख रहे हैं आपके जैसा बनने के लिए. देर आर मिलियंस ऑफ स्टूडेंट्स इन स्कूल हु वांट टू बी यू. So be grateful for what you have. Be proud of your journey so far. Okay, don't ever say कि सर आगे नहीं पहुंचेंगे तो क्या होगा. कुछ नहीं होगा. Be proud of your journey so far. You are already a winner. Okay, and with that note, with all of you winners, let us now start with the first topic of the day. Okay, everybody, you are already a winner. Okay, you are playing to win even bigger, but you are already a winner. So first topic that I'm going to start today is barium study. Okay, everybody, are you clear? Barium study. So for GIT, we give oral barium to look at the bowel loops. Okay, so they might ask you, what do we use in a barium study? Okay, what do we use in a barium study? Anybody? What do we use in a barium study? We use barium sulfate suspension. Everybody clear? So, and I want you to notice that I have written a Q8 over it. Even this has been asked as a MCQ once upon a time. They have asked this as a question, that what do we use for a barium study? The answer is barium sulfate suspension. Oh, why? Okay, why suspension? Because barium sulfate is not soluble in water. Okay, because barium sulfate is not soluble in water. My question to all of you is this: can you use barium for perforation study? If somebody has perforation peritonitis, can you use barium study? Can we use barium if somebody has perforation? The answer is no. We cannot use barium. Why? Because it is not soluble in water. It will become trapped in the peritoneum. And it will cause further chemical peritonitis. So if you have a patient with suspected perforation, which dye can you use? Just recall, I have already told you in one of my previous classes, what dye can we use if you have perforation peritonitis? The answer is gastrographin study. The answer is gastrographin study. Gastrographin is a water soluble iodinated dye that is used for bowel perforation studies. Clear? Now, immediately a question arises, what dye will you use for esophageal perforation? For esophageal perforation, the dye that we use is iohexol. For bowel perforation, gastrographin. But In thorax, we do not want a high osmolar dye because if it goes to the lung, it is going to cause pulmonary edema. So we prefer iohexol. But second thing to remember is we can also use barium swallow or barium sulfate. That means thorax, mediastinum and abdomen are different. In abdomen, we never use barium because barium causes severe peritonitis. But in mediastinum, you can use barium. So the first choice answer should be iohexol. If that is not given, then you can use barium. Barium does not cause severe mediastinitis. So barium is not going to cause inflammation in the mediastinum that much. So barium cannot be used in bowel perforation, but can be used for esophageal perforation. Everybody follows? Okay. Now try to identify the investigation. This is one of the, again a previous question, identify the investigation. Are you able to see this structure? What is this? This is the muscular tube which connects your mouth to the stomach. What is this? Esophagus. This is esophagus. Now, esophagus is if I am studying esophagus with barium study, I will use the term barium swallow. What is the name of the investigation? Barium swallow. Everybody follows? What is the investigation? Barium swallow. So let me answer the question that many of you are asking. Dekho, if you have bowel perforation, we use gastrographin because it is water soluble. But gastrographin has a drawback that it is high osmolar. In bowel, it has no problem because we don't mind a high osmolarity in the peritoneum. But if it goes into the lung, it can cause pulmonary edema. Esophagus being a thoracic structure, in thorax we don't want to use gastrographin because we don't want to use high osmolar compound. So esophageal perforation preferred dye is iohexol. What else we can use? What else can be used? We can use barium sulfate. Okay. Are you clear? Okay. Everybody follows? Okay. So, what are we looking at? We are looking at barium swallow. Now, second question, all of you. Let's see how many of you are able to answer this. Look at this particular barium study. Look at this particular barium study. This is your stomach. This is duodenum, duodenum, duodenum. Okay. So in this image, we are looking at stomach and duodenum. We are looking at stomach and duodenum. Name this study. If you are looking at stomach and duodenum, then we call it as barium meal, or we will say barium meal upper GI. This is not barium meal follow through. Okay, beta? Snehilata and I see Namra, 2-3 bachas are getting it wrong. This is not barium meal follow through. That is why I am showing you this, because this is a very, very important NEET question. They will ask you to identify the investigation. Some bachas will think that sir is telling so easy things, but in real exam they will do easy things wrong. This is barium meal, not follow through, beta. No, Sadhana Chaudhary, Swati Tamil, this is not follow through. Okay, this is barium meal because we are looking at stomach and duodenum, first part, second part, third part, and DJ junction. The barium is here, then there is some peristalsis, so it is not here. It is because of the peristalsis you are able to see such appearance. Okay, my question to you is this. Okay, let us make a conceptual question. Let us make a conceptual question. What structure is located in the star marked area? Okay. UGI means upper GIT, beta. Lahari, Dr. Lahari, it is upper GIT. Barium upper GIT. Okay. Now, what structure is located in the star marked area? In the star marked area, what would be located? If this is your duodenum, this is the location of your pancreatic head. So, in the star marked area, you have the pancreas or head of pancreas. So let us make a MCQ. Let's see how many of you are able to answer this MCQ. Widening of C loop of duodenum is seen in? Anybody? In which condition do you think the C loop of duodenum will get widened? In which condition do you think there will be widening of the C loop of duodenum? This C loop of duodenum will get widened if there is a tumor in the head of pancreas, because if there is a tumor in the head of pancreas, it will enlarge. So what is the answer? CA, head of pancreas. Clear, everybody? Now, do you notice now that we understood one thing, immediately MCQ was solved, and now you will never forget it. There is no need to revise. You will always remember. Widening of C loop of duodenum will be seen in cancer, head of pancreas. Okay, second question coming your way. What will you see? What sign will you see in a patient with periampullary cancer? Okay, suppose you have a cancer at the periampullary area, what will you see? So the question is, what will you see in a patient with periampullary cancer? Now suppose you have a periampullary cancer. Okay, let me just refresh.
Myocutaneous reflex.
Okay, are you able to see me now, everybody?
Myocutaneous.
Okay, now I think there's still some issue. Okay, I hope it should be better now. Okay, okay, now I will show you follow through also, don't worry. So suppose you have a tumor sitting here. What is this location? This is the ampulla of Vater. So if you have a tumor sitting here, it will cause some fixity. So wherever you have cancer, it will cause some fixity. So if you have a periampullary tumor, it will be sitting here, it will cause some fixation, so it will pull. So the duodenum, the second part of duodenum will have a shape like this. Are you clear? So if there is a tumor in the ampulla, it will pull the ampulla because of the fixity of the cancer. It will lead to this appearance. Anybody now tell me what is this lesion? Frostberg's reverse 3 sign. This is called as reverse 3 sign. Anybody now tell me? Anybody can answer this question now? In which condition do we see 3 sign on chest X-ray? 3 sign on chest X-ray is seen in coarctation of aorta. But if they say reverse 3 sign on barium meal, please mark periampullary cancer. Okay. Now, where is periampullary cancer? Where is periampullary cancer? Please try to understand. If this is your common bile duct and if this is your pancreatic duct, periampullary cancer is located in the ampulla, which is the junction of bile duct and pancreatic duct. Okay, periampullary cancer is located at the junction of CBD and pancreatic duct. So my question to you is this, and you will immediately solve a MCQ once I ask you the question, beta. Tell me, if you have a periampullary cancer and you do a MRCP, which duct will be dilated? If you do a CT scan, MRCP, which duct will be dilated if you have a periampullary cancer? Anybody? Both common bile duct and pancreatic duct will be dilated. This is called as double duct sign. Okay, this is called as double duct sign. So sometimes they might ask you a direct question, double duct sign on a CT scan, on a MRCP, or will be seen in periampullary cancer. Okay, both will be dilated. This is called as double duct sign. I think Rashika Shekhar got it right, and I think one more, Sushma Raj also got it right. So are you clear, beta? So let me revise for you. So the key word was, this is your duodenum, C loop. This is where you have the head of pancreas. So if you have a tumor in the head of pancreas, the duodenal C loop will be widened. If you have a tumor in the ampulla, you will see the reverse 3 sign, and you will also have double duct sign. Okay. Do you understand now? Reverse 3 sign is a barium sign. It is a barium sign. Yes, beta. Now, my question to you is this. Somebody is saying why both? Because ampulla is the place where bile duct and pancreatic duct are joining. My question is this. Okay. And you will have that waxing and veiny jaundice also that you might have studied in your surgery. Now, second question now. Now, why this has been asked in the past exams? Try to imagine now, before CT scan was invented, the only way we could see a tumor in the pancreas was to look for indirectly by looking at the barium study. Okay, are you clear? Are you able to understand this? That earlier we could only look at a pancreatic tumor based on indirect evidence. But now if they ask you, what is the investigation of choice for CA pancreas, what will you mark? Anybody? What is the investigation of choice for CA pancreas? Anybody can answer? Investigation of choice for CA pancreas is now CT abdomen. This CT should be done with pancreas protocol, or we can say it can be a triple phase pancreas protocol. Okay, the better answer will be CCT or triple phase pancreatic protocol. I'm again repeating. Okay, the question is, what is the investigation of choice for CA pancreas? The answer is CCT or triple phase pancreatic protocol. Now suppose if they change the question, and they say, what is the investigation of choice to localize insulinoma? Suppose in pancreas you want to locate a insulinoma preoperatively, what investigation will you use? So again the answer should be CECT. Because in pancreas we prefer CT scan, but insulinomas are very, very small. Sometimes they are missed even on a CT scan. So that is why if they say insulinoma and they ask IOC to localize, best answer is endoscopic ultrasound. If that is not in the choice, then you mark CECT. Clear? Are you able to see this? Okay. Now एक बच्चा कह रहे सर हम डबल डक्ट क्यों देख पा रहे हैं अगर हम डाई दे रहे हैं? नहीं बेटा, MRCP, I told you ना, MRCP is done without giving any dye. Okay, dye is given in ERCP. MRCP में तो कोई dye दे ही नहीं रहे, so we can see the ductal dilatation. Clear? Everybody now quickly answer. I am again repeating for you 3 questions, all 4. I think we have seen 4 or 5 MCQs. Widening of C loop of duodenum, CA head of pancreas. Frostberg's reverse 3 sign, periampullary cancer. Double duct sign, periampullary cancer. IOC for CA pancreas, CECT, preferably triple phase CT. IOC to localize insulinoma, endoscopic ultrasound. If that is not in the choice, CECT. Okay, are you able to understand? Okay, now let's go further now. Anybody now, especially the bachas who were getting it wrong, I want you to look at this picture and answer. Okay, so we have covered some MCQs with that image. Now I want you to see what is this part of the bowel that you see now. You have given barium orally, and now you have followed the barium from stomach to small bowel. The barium has gone into the small bowel. Okay, anybody now tell me, barium has gone into the small bowel. What test is this? This is called as barium meal follow through. What is the investigation? Barium meal follow through. This is barium meal follow through. Okay, everybody understands? Okay. Okay. Now, second question. I'll explain to you what about the radiation exposure also, but listen to me first. Okay, listen to me first. Barium meal follow through, we look at the small bowel. But small bowel will have two parts. You will have jejunum and ileum. Okay. I want you to identify with me. I want you to identify with me. I want all of you to see, this is last year's FMG question. If you can answer better. Very important. Can you see this part of the small bowel has complete folds? It is feathery, it has folds. This part of the bowel is feathery and has volvulae conniventis. Complete folds called as volvulae conniventis. Okay. Okay. So far, all the images that I have shown are normal images. Normal images. Okay. So these are volvulae conniventis. If these are volvulae conniventis, tell me what is this? This is jejunum. So which part of small bowel will have feathery appearance? Jejunum. This is your normal jejunum. So far we have seen barium swallow, barium meal follow through. Barium has been given orally. Barium has been given orally. Are you clear, beta? Now, as we go from jejunum to ileum, the number of folds reduce. So I want you to now appreciate this part of the bowel. I will just mark it for you. Appreciate and see this part of the bowel. In the distal part of the bowel, distal part of the small bowel on towards the right side, there are almost no folds. That means distally the part of the small bowel is appearing characterless or featureless. अब बताओ. Okay, anybody now? If the barium is seen in the bowel, small bowel, but you don't see folds, it is featureless, then it is ileum. Then it is ileum. Everybody follows? Okay. So sometimes in the exam, although you might be preparing for hi-fi things, sometimes they just ask you to identify the small bowel loop. This is jejunum. And normal investigation, normal anatomy is very important from MBBS perspective on radiology images. Sometimes they may not ask you disease. They might only ask you the abnormality. They might only ask you the normal structures. Okay. Second question now. Let's create a MCQ out of it. Suppose in the small bowel you have a tumor called as gist. What is gist? Anybody has heard of gist before? What is gist? Gastrointestinal stromal tumor. What is gist? Gastrointestinal stromal tumor. Arises from the interstitial cells of Kahal. Gastrointestinal stromal tumor arises from interstitial cells of Kahal. Okay. My question to you is this. Where will you see gist? I will explain to you. Listen to me and then I will ask you the question. Suppose this is your bowel loop. Gist will be located somewhere here. So my question to you is, gist will be within the lumen of the bowel or it will be outside? Anybody? Anybody? Gist is a exophytic tumor. Exo matlab bahar ki taraf. It grows outside the bowel. Okay. Now the question here is, for gist tumor, investigation of choice is endoscopy, barium meal follow through, CECT. I want all of you to answer and give me the logic also. Okay, I have already given you the hint. Now tell me, this is how they create MCQ in the exam. So, because if you don't understand, you will get it wrong. Gist tumor, what is the investigation of choice? Now the important word here is gist is a exophytic tumor. It grows outside the bowel. So it will not be assessed on endoscopy or barium study, because endoscopy or barium study will see the lumen, while this tumor is in the outside the lumen. The answer is CECT. Is that clear now? So small bowel tumors, gastrointestinal stromal tumors, if they ask IOC, please go for CECT, because these tumors are often exophytic. Okay, I think I can see most of you are able to answer the question correctly. Okay, let me ask you another question now. Okay, I'm revising for you. Barium swallow, barium meal follow through. Now I want you to look at this image and tell me, where is the barium? Now in this you can see the large bowel or the colon, and I can identify it because of these incomplete folds. What are these folds called as? These folds are called as Hostrae. Now anybody tell me, I cannot see the barium in the stomach, I cannot see the barium in the intestine, but it is in the large bowel. So do you think barium has been given orally? Do you think it has been given orally? No, it is barium enema. You have given barium per-rectally through the enema. Now important question here is, if I have to compare the radiation exposure, if they ever ask you the radiation exposure in a radiological investigation, maximum radiation exposure is seen with a PET CT. Okay, maximum radiation exposure is seen with a PET CT, a CT PET, which I will explain towards the end of my class, followed by cardiac CT, followed by abdominal CT, followed by chest CT, barium enema, okay, CT brain, mammography, chest X-ray. Okay, now I want all of you to see this sequence, very very important. So do you realize, out of all the barium studies that I have shown you so far, barium enema has the maximum radiation exposure out of the other barium studies, and abdomen CT has more radiation than barium enema, cardiac CT has more radiation than abdominal CT, PET CT has maximum radiation exposure. Okay, now this is how you will answer in the exam. This is the sequence of radiation exposure for common investigation. Also notice, mammography has more radiation exposure than a routine chest X-ray. Mammography has more radiation exposure than a routine chest X-ray. Okay, clear? Now why barium enema has more radiation exposure? Because it is done constantly under fluoroscopy. You keep looking under fluoroscopy and see how the barium is going into this large bowel. So in the ultimately you expose the patient to more radiation in barium enema as compared to other barium studies. Okay, now another question that Neeraj is asking, mammo is ultrasound. No beta, mammography is a X-ray technique, it is not a ultrasound. It is a good thing that you realize this. I will explain this further when I am explaining the radiation physics tomorrow. Mammography is based on X-rays. Interesting? Okay beta. Now once you are able to understand the concept, we are able to see this. Let's go a little bit more further. This is how the normal large bowel should look like. This is the transverse colon, descending colon, sigmoid colon. Okay. Now sometimes they will say which part of the large bowel, which part of the colon is least evaluated by barium enema. Please mark the answer as sigmoid colon. Can you tell me why? Because sigmoid colon tends to get overlapped, because it is having, sometimes it is more redundant, it has a sigmoid mesocolon. Sometimes because of the overlapping you may not be able to fully see it. So part of the colon which is least evaluated by barium enema, sigmoid colon. Okay. Now one bacha is saying, sir, where is pylorus in the barium mean? ये वाला ना बेटा, that is we cannot see it here because of the peristalsis. ये हवा दिख रहा है ना इसके अंदर. Please see, barium you have given, but it will move with peristalsis. So if you have a contraction here, then the barium has gone into this part. It is peristaltic. So in bowel you will always see peristalsis. So some part will have barium, some part will not have barium. Even in ureter, in IVP, we saw peristalsis. Okay. Now, one bacha is saying, sir, how much radiation is considered safe? Don't worry, I will talk about radiation physics tomorrow. So let's not disturb the flow of the GI imaging. Okay. Let's go and see the first disease X-ray. So far, I have shown you only the normal. Now we will see the abnormal. Anybody tell me, look at the image and tell me which structure is abnormal. It is the esophagus which is dilated. Esophagus is dilated, grossly dilated esophagus. Plus, what do you see? Along with the gross dilatation of esophagus, we can also see the bird beak tapering of the distal esophagus. Bird beak appearance at the distal esophagus. This is one MCQ that they will keep showing in the exam. You can't do this wrong. Every year it is asked, even in the INI exam, NEET exam. What is the diagnosis? Achalasia cardia. Achalasia cardia. And they will ask you, okay, they will ask you that what will you do next? So if you suspect achalasia on barium, what will you do to confirm? What will you do next to confirm? Tell me. Which investigation you will do now to confirm the diagnosis? Anybody? Last year's INI-CT question. How will you confirm? The barium is suspicious of achalasia. What will I do to confirm it? Anybody? The answer is manometry. It is confirmed by manometry. Everybody understands? Clear? So barium is the first thing to be done, but the confirmatory will be manometry, and I can see most of you are able to answer. One bacha is saying, sir, if we do bone scan, so where will you have the radiation exposure of bone scan? That is a good question. Bone scan will be somewhere here. Okay, beta? Clear? Bone scan will have a radiation exposure more than the CT brain, less than the CT abdomen, in between. Okay. Now one bacha is saying, sir, what about sigmoid colon? Okay, मैं दोबारा बता देता हूँ. Sigmoid colon is a very redundant kind of a structure. So it is very mobile. So can you see it is all overlapped? Two loops are getting overlapped. So it is least evaluated by barium enema because it tends to get overlapped. So some part may be missed on a barium study. That is what I wanted to make sure that you understand. Okay, beta. Now, in your exam, whenever they show you achalasia, they ask you what is next to be done. The answer is manometry to confirm this very important question. Second, they will try to confuse you by showing you this image. Anybody? Mano means pressure measurement, beta. Jyoti, it means pressure measurement. Now, anybody can tell me, as compared to previous image, what is this? In this particular image, you have narrowing of the esophagus, which looks like a rat tail, and the borders of the esophagus above the rat tail are showing shouldering, or we can say apple core appearance. So if I say this is how it is looking like, okay, Are you able to understand this? So there is narrowing like a rat tail with overhanging edges, which can be called as shouldering or apple core appearance. What is it? What can we call it? Then we think of CA esophagus. Okay, then we will say CA esophagus. Now my question is, both are the same patient, just slightly oblique beta. One image is slightly more oblique just to show you the tumor. My question to you is, anybody, CA esophagus is diagnosis is made by, diagnosis is done by endoscopy and biopsy. Diagnosis of CA esophagus is done by endoscopy and biopsy. Immediately the question will be, anybody can answer this very important question. T staging or local staging of CA esophagus is done with. Anybody? T staging or local staging in CA esophagus is done with. Anybody? This is a very important question. You should always mark the answer as endoscopic ultrasound. Endoscopic ultrasound. Any one of you can tell me one more question where I gave the answer as endoscopic ultrasound? That was to localize insulinomas. To localize insulinomas, we use endoscopic ultrasound and T staging in CA esophagus. But however, if they mention in the question only the word staging, or they use the term distant metastasis, what will be your answer? Suppose they do not say local staging, they are saying staging, or they are saying distant metastasis. What will you mark as the answer? Then your answer should be PET CT. Okay, then your answer should be PET CT. Clear, everybody? Are you able to mark it? Then your answer should be PET CT. Okay. So barium has a classic image, but it is not done for staging. Staging is done, local staging by endoscopic ultrasound, distant metastasis by PET CT. If they only use the word staging, go for PET CT as the answer. Okay. And looking at the chat box, I think it was straightforward for you. But this was a question that was asked recently in the UPSC exam. They said, if you want to look for distant metastasis in bowel tumors, what will you do? The answer was PET CT. So I will say, some bachas are saying why we are using PET CT. Don't worry, I will explain PET at length towards the end of the class. I'll tell you why PET is able to see cancer. I will tell you today. Don't worry. Okay. Now, what is EUS? EUS is, Harshvardhan, it is endoscopic ultrasound. Endoscopic ultrasound. Clear? Okay. Staging means when we want to see TNM, distant metastasis, nodal metastasis, then we are using PET CT. But if we only want to see the local local spread of the cancer, we want to see how deep it is going into the esophageal wall, we will use endoscopic ultrasound. Okay. Now, these two images are both barium swallows. One is achalasia, one is CA esophagus. Okay. Everybody follows? Okay. So this is how they will frame the questions on the side. This is how they will show you the image, and these are the two most important questions on esophagus. Now let's go slightly into more more complicated things. This is again a barium swallow. Everybody, this is again a barium swallow. I want you to tell me what has happened to this barium swallow. What is this condition? Let me tell you that this has been asked as a previous NEET PG image. Now tell me, you can see multiple non-propulsive contractions in the esophagus, which are giving rise to a appearance which is called as corkscrew esophagus, seen in a condition called as diffuse esophageal spasm. What is your diagnosis? Diffuse esophageal spasm. The appearance is corkscrew esophagus. This is what is called as corkscrew esophagus. So you can now see that what I am trying to do is I am trying to show you the common pathologies. First we saw the normal. I am showing you common pathologies which can be asked directly as a image based question in your exam. What is your diagnosis? Diffuse esophageal spasm. Okay. Now let's try to solve one more image. If I say this is a barium swallow, can you find out what is wrong with this barium swallow? Can you find out what is wrong in this barium swallow? There is a filling defect. There is a filling defect. What is the shape of the filling defect? There is a smooth concentric filling defect in the esophagus. Okay. My question to you is, this filling defect, is this causing obstruction of the esophagus? No. You can see the barium can easily pass. So it is not causing stenosis, not causing narrowing, not causing stenosis of the esophagus. That means this is not cancer. If you remember, I just showed you a patient with esophageal cancer. If you remember, I just showed you a patient with esophageal cancer. Cancer will constrict. Cancer will, cause stenosis. It will cause narrowing of the lumen. But in this particular case, there is a filling defect in the esophagus, but barium is only pushed to other side. It is not getting obstructed. That means we are looking at something which is having a smooth mucosal outline. So it is submucosal. What is that? It is a leiomyoma of the esophagus. It is a leiomyoma of the esophagus. A benign tumor, so it will have smooth margin, concentric filling defect, which not causing a stenosis. The barium can still move freely. This is a leiomyoma on the barium study. Okay, everybody follows? Everybody follows? Okay. So far, I also want you to remember, in the exam, they will not show you anything which is subtle. Goku Tiwari, they will always show you something which is very obvious. है ना? ऐसा छोटा सा बीमारी नहीं दिखाएंगे exam में. They will give you clearly that, okay, this is such a big leiomyoma, easy to see. In the exam, don't think that the examiner is going to test you to become, they are not testing you as a radiologist. They only want to see if as a MBBS student, if you are able to pick up the pathology or not. Okay, just normal things, usual things, easy to pick up. Okay, don't go for rare things. Okay, now why barium go in the right side of a dark area? Now this is what is happening is, this patient has a submucosal leiomyoma. Leiomyoma is below the mucosa, so it is not causing the constriction. It is just pushing the barium column. So barium is still able to pass through the esophagus. There is a filling defect, which is your leiomyoma. Okay, Fenil Jagdish. Okay. Now somebody is saying why this is not perforation. Perforation होगा तो barium बेटा बाहर निकलेगा, ऐसे बाहर आ जाएगा. Esophagus के बाहर आता ना. If it was perforation, the barium will come out. Okay. Now let's move further. What is somebody saying? What is filling defect? Filling defect means that, if the organ is full of dye, you have some lesion inside which is not allowing the dye to fill in that area. So this is what that filling defect in this particular patient is. Okay, this is your leiomyoma in this patient. Okay, everybody. Now let's go further. In a normal person, when we look at the esophagus, we should see longitudinal folds. Normal esophagus will have longitudinal folds like this. Okay, but never transverse folds. Now the question is, if you see transverse folds in the esophagus, what will you suspect? Please zoom in and see. Can you see in this case? Esophagus has transverse folds. So if you see transverse folds in esophagus, this is abnormal. Can you name the cause? Transverse folds in the esophagus are abnormal in humans, but in cats they are normal. So we call it as feline matlab cat esophagus. If you see prominent transverse folds in the esophagus, it is called as feline esophagus, cat-like esophagus. What are the causes? The most important cause is GERD, gastroesophageal reflux disease. If the acid refluxes from stomach to esophagus, when the acid comes in contact with the esophagus, it causes spasm of muscularis mucosa. It causes spasm of muscularis mucosa, leading to transient folds in the esophagus. So whenever they say feline esophagus seen in, please mark the answer as GERD. Now suppose they say name one more cause, then also remember eosinophilic esophagitis. Eosinophilic esophagitis leads to, this is a barium study. Yes, so far we have only seen barium studies. Eosinophilic esophagitis leads to permanent folds in the esophagus, permanent transverse rings or folds in the esophagus. Then the term that has been used here is, we use a term trachealization of esophagus. We use the term trachealization of esophagus. Sometimes they will ask you a question, okay? In which condition do we see trachealization of esophagus? What is your answer? Eosinophilic esophagitis leads to permanent ringed esophagus. Just like the trachea, esophagus in this condition will have rings. That is called as trachealization of esophagus. Okay. While in GERD, if you have acid reflux, okay, मिशिका राव, acid आया esophagus के अंदर, तब ऐसा होता है. Okay. Now somebody saying why not esophageal web? Web जो होगा ना बेटा एक जगह पे होगा क्रिकॉइड के पीछे, बट ये तो बहुत सारे हैं ना. क्लियर? संग्राम कुमार, कैन यू सी दिस आर मल्टीपल ट्रांसवर्स फोल्ड, बहुत सारे फोल्ड्स दिख रहे हैं ऐसे. दिस इज व्हाट इज कॉल्ड एज फेलाइन esophagus. It is seen due to GERD and eosinophilic esophagitis. Okay, common questions. Now let us now go to the next part. If I follow the GIT from esophagus, then next you should have stomach. In stomach, in a infant, you should always look for this condition. Anybody, what is the investigation? What is this investigation? This is ultrasound. If this is an ultrasound, what is this structure? This is your liver, this is your stomach, and this is the problem. Can anybody tell me what is the problem? Can anybody tell me what is the problem? Okay. This is your hypertrophied pylorus. Now one बच्चा is saying, sir, transient और permanent में क्या फर्क है? GERD में the feline esophagus that forms is only during the reflux. After that it becomes normal. It is a transient phenomena. While in eosinophilic esophagitis the folds are permanent. They do not change. They are fixed. So if you see during the reflux on endoscopy folds forming, that is GERD. If it is more fixed, then we think of eosinophilic esophagitis. So what is this? The hypertrophic structure is your pylorus. This is congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis. Investigation of choice. Investigation of choice is anybody? Ultrasound. Investigation of choice for congenital hypertrophic pyloric stenosis is ultrasound. Now let's see and answer this image, and I'll just try to outline it for you. This is your liver, beta. This area is your liver, and this is your stomach with the some food or liquid inside, and the pylorus, this is pylorus which is not opening. This area is your pylorus. Clear? Now the pylorus is hypertrophied. How do we know hypertrophied? It is not opening, plus if we see the length of this pylorus, if it is more than 16 mm and the thickness of the wall more than 4 mm is the ultrasound criteria for CHPS. Investigation of choice, ultrasound, length more than 16 millimeter of the pylorus, wall thickness more than 4 millimeter. Think of CHPS on ultrasound. Okay. Now earlier we used to think that we can do a barium here, but now ultrasound is very good and it is easily able to diagnose CHPS. Gradually in pediatric conditions we are using ultrasound more and more. I will explain to you. I will explain to you, beta. Please see. Suppose they say a pediatric patient has suspected acute appendicitis. Suppose in a child you are suspecting acute appendicitis or acute intussusception. What investigation will you do if you see these questions in a child? Anybody? Now in children, if you are suspecting appendicitis, this is a previous INI-CET question, or intussusception, please go for ultrasound as the answer. Please mark the answer as ultrasound. However, if they say adult with suspected appendicitis, then what will you mark as the answer, beta? Adult with suspected appendicitis. Then you should go for CECT as the answer. So ultrasound has a role to play in children. It can diagnose congenital hypertrophic pyloric stenosis. It can even help you to diagnose appendicitis in a child. And you can see now how in the exams like AIIMS they will trick you. They will say acute appendicitis investigation of choice, go for CECT. But if they say appendicitis suspected in a child, go for ultrasound as the answer. Now before I go and give you more context here, I just want you to remember one line. On ultrasound, appendicitis is seen as a tubular, non-compressible, blind ending structure more than 6 mm in diameter. This is a possible next question that they may ask you in the central exams. Acute appendicitis. Okay, I will explain why, beta. I think some bacha is saying, Shamuga is saying, sir, why? I will explain, beta, why be. Lekin ek baar batao. How will you identify appendicitis? When I do an ultrasound, appendicitis will be tubular, non-compressible, blind ending, more than 6 mm in diameter. Remember the criteria. 6 mm se zyada inflamed hai, less than 6 mm normal hai. But why in adults, why we are not using, what is the difference? Let me explain. Okay, so I will make another MCQ for you. On your question, I will make a question. Okay. Why ultrasound is preferred for pediatric acute abdomen? Okay. Now, this is the question. Why we prefer ultrasound in pediatric acute abdomen? Anybody? बच्चे में हम क्यों प्रेफर करें? नंबर 1, नो रेडिएशन. In children, pregnant ladies, we always want to avoid radiation exposure. So ultrasound has no radiation exposure. It is based on sound. Number 2, no sedation is required. It is very important. Okay. It is very important to understand when we do CT scan. When we do CT scan, the patient should not move. Whenever we are doing a CT scan, patient should not move. Okay. But if it is a child in a CT scan, he will move. He doesn't know. Okay. So we have to sedate the baby. But in ultrasound, you can have the baby in the comfort of the mother's lap with his mother, and you can easily do ultrasound without sedation. Okay. The third thing is, which is very important, and this is the question that Yashasvi is asking. Let me answer. Let's see. बेटा देखो, okay, everybody listen to me, look at me, you will get your answer. एक बात देखना बहुत जरूरी है बेटा, देखो बहुत जरूरी है, देखो मेरी तरफ. Everybody look at me, everybody look at me. देखो, see, when we are small children, our abdomen is like this. Okay, when we are children, our abdomen is like this. When we grow up, we not only grow tall, we also grow. Okay. Now the problem with ultrasound is more the frequency, better the resolution, but the penetration will not be there. So if you have an adult, okay, if you have an adult, now what will happen? I need to go more deep as compared to child where the abdomen is very small. So children, the advantage is, listen to me, high frequency ultrasound can be used, which gives you better resolution. Are you clear? While in an adult, the abdomen will be larger in size. That's the issue. Are you clear now, beta? Are you able to understand? Okay, now are you able to understand why thin people you can use ultrasound still, but not in fat people? That happens. So, but this is the reason. And even this can be asked as a MCQ in your exam. Okay, remember, no radiation, no sedation required. High frequency ultrasound can be used if I use ultrasound in children. Clear? Everybody gets the logic? Logic is clear? Okay. Now, somebody said, sir, appendicitis का criteria क्या था? दोबारा से बता दो. Okay, so let me just repeat for Nivedita that acute appendicitis on ultrasound should be a tubular, non-compressible, blind ending structure with more than 6 mm diameter. Now, one बच्चा is saying, sir, intussusception में क्या logic है? अब ये तो बता ही दो आप, है ना? Intussusception in a child, ultrasound. In a adult, CECT. Intussusception in a adult, CECT. Why? देखो, I hope you know it or not. I will just tell you. In children, intussusception is happening during the weaning. You know, when the child starts taking solid during the weaning time, hypertrophied Peyer's patches act as a pull and you develop the intussusception. In adult, intussusception happens due to a tumor in the intestine. So to see that tumor, we need to do a CCT in adults, but in ultrasound in children, we just need to demonstrate intussusception by using a target sign. Okay. Okay. Now this is your hypertrophic pylorus. If I look at it in a cross section, if you look at it in a cross section, it will look like a target. But if they ever show you the image of congenital hypertrophic pyloric stenosis in the exam, this is the image that they will show you. Okay. Now let's go further. So we have seen one concept about role of ultrasound in pediatric imaging, role of ultrasound in CHPS, and how to identify. And before I go on, one बच्चा is Mishika is saying again कि सर पता कैसे चलेगा compressible नहीं है? देखो बेटा, हम ultrasound कर रहे हैं. Mishika Rao, see, when I'm doing ultrasound, I will compress and see if it is compressing or not. Okay, ultrasound is a dynamic investigation. You can do some things when you're doing it. Okay, some people are going. Harshita is saying, sir, see breast के बारे में बताओ. अभी mammography आएगा, फिर बताएंगे. I will tell you later on. Just focus on bowel right now. Don't go on to the breast imaging immediately. I will talk about it. Okay. Now, my question is, I want all of you to look at this barium image and tell me, is this CHPS or not? Is this CHPS or not? Okay. Anybody? Anybody? Is this CHPS or not? The answer is no. This is not CHPS. Why? Because I can see the stomach, I can see the duodenum, and I can see the jejunum also. So the barium in CHPS should be in the stomach, but here it is going into the duodenum, into the jejunum, like this. Now second question is, what is happening here? Jejunum is present on this side in this patient, while in a normal person jejunum should have been here. Do you remember? Listen to me all of you, listen to me all of you. If this is your stomach, the duodenum should end towards the left of the spine and jejunum should be on this side. In this patient, the jejunal loops are forming here. What should I suspect? Why is the jejunum on the opposite side? I am thinking of malrotation. This child has malrotation. But then if the child has malrotation, why is the barium not passing freely? It is forming a corkscrew-like appearance here. There is a corkscrew-like appearance at the DJ junction. Duodenojejunal, okay, let me write in full only, otherwise bachas will get confused. Duodenojejunal corkscrew appearance. Why? Now if it is malrotation, then what has happened? Now try to understand. Try to understand. Normally jejunum should be at the area where I have written my J. DJ junction to ileocecal area is the root of the mesentery. If your bowel is malrotated, the mesentery becomes, root of the mesentery becomes shorter. Try to understand. Okay, try to understand. If you have malrotation, DJ junction, duodenojejunal flexure, instead of being on the left side is on the right side, so the root of the mesentery becomes smaller. So if the bowel is hanging on a small attachment, it becomes hypermobile. If it is hypermobile, it can undergo twist. And if it undergoes twist, you will see a corkscrew-like appearance. What is this called as? This is called as small bowel, or we can use a term midgut volvulus. This is called as midgut volvulus. Okay, are you able to understand this? That we are trying to do a barium study, but the barium is not going beyond it. It seems to have a corkscrew-like appearance at the DJ junction. Always think of midgut volvulus. This is not CHPS. This is midgut volvulus. Okay, why it is developing? Because it is predisposed in children with malrotation. If you have a child with malrotation, the mesenteric attachment is shorter, which predisposes you to develop midgut volvulus. Okay, everybody. So Surbhi and Diksha, I am repeating for you again. If you have malrotation, the mesenteric attachment becomes shorter. That means the mesentery is attached, it becomes shorter. So the bowel becomes, small bowel becomes hypermobile and predisposes you to develop midgut volvulus. If you have midgut volvulus, DJ junction will show a appearance like this. What is this appearance? Corkscrew-like appearance. Corkscrew appearance of the duodenojejunal area is midgut volvulus. Always remember, this is different from a corkscrew esophagus. Corkscrew esophagus was seen in diffuse esophageal spasm. Corkscrew duodenojejunal area, midgut volvulus. Okay, everybody follows? Okay, so this is a barium meal follow through study which was being attempted, but because the barium is not able to pass beyond this, and you see kind of corkscrewing happening here, we are able to make the diagnosis of midgut volvulus. Okay, now let me ask you another question. So in the stomach we talked about CHPS, but even more important is to talk about ulcer. Okay, in the stomach, everybody try to understand. Okay, volvulus means bowel twisting on its own axis. But if it is hypermobile, it is likely to twist on its own axis. That is what I said, Sindhu Arunagiri. Okay. Now, suppose you have a ulcer in the stomach. Okay. Okay. My question is, if you have ulcer in the stomach, I think Gayatri is getting. I said small bowel, mid-cut volvulus, मतलब small bowel volvulus हो रहा है पूरा का पूरा. Okay. Okay, everybody quickly answer. If you have an ulcer in the stomach, there are two possibilities. Either we are dealing with a benign ulcer or a malignant ulcer. How will you differentiate? How will you differentiate between a benign ulcer and a malignant ulcer? Okay, I will explain to you. I will explain to you. एक बार देखो मेरे साथ and let's try to solve the concept. Suppose, okay, suppose you have, this is your ulcer. Suppose in the stomach you have an ulcer. Suppose it is a benign peptic ulcer. Okay, everybody tell me, if you have an ulcer, what will it cause? Anywhere you have an ulcer, it will ultimately lead to fibrosis. It will lead to fibrosis, scarring. So if you have fibrosis, what will happen? The gastric rugal folds will be converging onto it. They will be pulled towards it. Okay, now I'm repeating. Everybody listen to me. Gastric folds are seen radiating from the ulcer margin. Okay, everybody, gastric folds, if they are seen radiating from the ulcer margin, we will say it is a benign ulcer. I will show you how it looks like. I want all of you to see this barium meal. This is the area where you have an ulcer, and these are your gastric folds. Okay, these are your gastric folds. Now I want all of you to see, I am removing my marking. Please see with me. Can you see these gastric rugal folds? Yes, and this they are converging onto this puddling of barium. That is your ulcer. This is where you have the ulcer. So what is this? This is a benign peptic ulcer of the stomach. Why it is benign? Tell me. Because the gastric folds are seen radiating from the ulcer margin. Now you might ask me, sir, if it was cancer, what will happen? If it was cancer, we will call it malignant ulcer. So if it was cancer, what would happen? In cancer, suppose this is a ulcer, we know by now from your basic knowledge of surgery that any cancer ulcer, malignant ulcer, should have heaped up margins. So ulcer, a malignant ulcer is a cancer which has ulcerated, so there will be ulcer surrounded by heaped up margins, and this is where you will have your gastric folds. So in a malignant ulcer, gastric folds do not reach the ulcer margin. Can you mark it? In a malignant ulcer, gastric folds do not reach the ulcer margin. Okay. While in a benign ulcer, they are seen radiating from the ulcer margin. Okay. Now, clear? Oh, somebody saying, sir, how do we know this stomach? Because you can see the rugal folds. These are the rugae. Thick folds like these are not seen in any other bowel part. In esophagus, you don't have these rugal folds, beta, Pujali. Okay. Now, my question is this. Now, again, I will again re-emphasize that try to focus on what I'm saying in the class, because that will help you in the exam. We can see the ulcer from the front, and we can see it on the barium from the side. If I see the ulcer on profile, that means on the side, a benign ulcer will be seen as a outpouching. A benign ulcer will be seen as a outpouching on a barium meal. Please see this area. The barium has gone into the stomach. Ulcer is a defect in the mucosa. So barium has gone into that defect. So on a barium study, if you have a benign gastric ulcer, it will look like a outpouching. Can you see it here on the lesser curvature? Outpouching. This is a benign gastric ulcer. Okay. Now, second question is, if you have a ulcer in the duodenum, if you have the ulcer in the duodenum, what will happen? Now, suppose this is your duodenum. Duodenum first part is shaped like a cap. But if you have fibrosis there, if you have fibrosis, chronic ulcers, it will become like this. If you have fibrosis, it gets contracted and it becomes trifoliate. I want you to see this particular area, and then I will repeat everything. Don't panic. I want you to see this particular area. Can you see here? Now this is where you should see a cap-like duodenum, but this area is all distorted, fibrosed, and it has become trifoliate. We will call this as chronic duodenal ulcer. Okay. And both these two images are barium meal studies. We are looking at barium meal studies. Okay. So instead of saying AP and lateral, we are saying from the front and from the profile, just to make it more easy, because it may not be true lateral, but we are trying to look at the ulcer on its profile, ulcer from the front. So ulcer, if you look at it end on from the front, will show benign ulcer will show folds radiating from the margin. Malignant ulcer, the folds will not reach till the ulcer margin because margin is surrounded by tumor. Benign ulcer will be seen as a outpouching. A benign duodenal ulcer will lead to a trifoliate duodenal bulb. Okay, and this particular structure, this is the outpouching beta. I think one Sakshi Gupta is asking, sir, ye raha outpouching beta, ye wala. Okay, but what about, okay, okay, this particular patient has both, Namra, very good. This particular patient has both ulcers. He has a gastric ulcer also, duodenal ulcer also. Both of them are peptic ulcers. Now, what about malignancy? This is slightly difficult, but try to understand with me. Suppose this is your stomach. Suppose this is your stomach, and suppose you have a tumor sitting here, a cancer. And suppose this cancer undergoes ulceration. Okay, so this is how it would happen. You have a cancer and on the top you have a ulcer. This is how a malignant ulcer will be. If you give barium to this patient, what will happen? If I give barium to this patient, barium will go into the esophagus, into the stomach, it will go into the ulcer. So if you give barium, it will look like this. I will show it to you with a diagram. The stomach contour will actually look like this. So the tumor will become a filling defect. We will not see it. The barium will be seen like this. I will just make sure that you understand. There will be filling defect and slight dip into the ulcer part of the tumor. This appearance where the ulcer appears to have convex margins towards the stomach is called as Anybody? It is called as, anybody knows this? It is looking like a convexity, looking like a meniscus. So we will use the term after the man who described Karman's meniscus sign. Okay, so sometimes they might ask you a direct one-liner in the exam. Karman's meniscus sign is seen in. The answer is malignant gastric ulcer. I am again repeating. Now please see. The images that I am showing you here are benign. The diagrams that I have made are cancer. Okay, I am repeating now. Listen to me, all of you. Those of you who could not follow, I am repeating, and listen to me. It should give you the clarity. Benign ulcer is seen as a outpouching from a barium study. If you look at it from the front, you will see gastric folds radiating from the margin of the benign ulcer. Malignant ulcer, with the gastric folds cannot reach till the ulcer margin, and it will show convexity towards the lumen, which is called as the meniscus or the Karman's meniscus sign. And Harish is rightly saying it is also called as the Kirklin complex, Karman meniscus sign or Kirklin complex. Okay, so these are the name of the people who described this appearance. So sometimes they use this term. So far in the stomach, I have told you how to identify congenital hypertrophic pyloric stenosis, how to differentiate benign ulcer from a malignant ulcer, and where to use ultrasound, where to use CT. We've talked a little bit about these things. Okay. Now, एक बच्चा कह रहा है सर ये chronic क्यों है duodenal ulcer? I think Akash is saying. अच्छा एक बात बता बेटे, Akash Maheshwari, please tell me. Now, can you see the lumen is become narrow? Why would bowel lumen become narrow? If you have fibrosis. And fibrosis happens in acute inflammation or chronic inflammation? Fibrosis happens in chronic inflammation. So this is chronic ulcer because it is all fibrosed and deformed, leading to trifoliate appearance. Okay, Manoj Kumar? Okay, trifoliate appearance is a result of fibrosis happening in a long-standing duodenal ulcer. Now, for ulcers, barium is not the investigation of choice. You will definitely evaluate them on endoscopy, but barium is the investigation where we are looking at in radiology. That is why I am teaching you here. Same things you will read in pathology also. That pathologists also differentiate with the same methods. They differentiate benign and malignant gastric ulcer. Okay, now my question is this, beta. Suppose ulcer perforates, then what will happen? Suppose the ulcer perforates, what will happen? Okay. If the ulcer perforates, what will happen? If the ulcer perforates, you will see perforation peritonitis, you will see gas below the diaphragm, and this is how it will look like. I want all of you to see this particular X-ray. It is multiple times asked in your exams. You cannot do this wrong. Please see this area. This is gas below the right diaphragm. This is pneumoperitoneum. What is this X-ray showing you? Pneumoperitoneum. Everybody gets it? Gas below the diaphragm, pneumoperitoneum. Very quickly, I will give you 2-3 questions to answer. Let's see how many of you are able to answer my questions. Okay, question number 1. Very often asked. What is the best X-ray to detect pneumoperitoneum? Anybody wants to tell me? What is the best X-ray to detect pneumoperitoneum? बोलो. Now some बच्चे saying left पे भी तो है ना. हाँ सही बात है, but left पे ना stomach भी है ना, तो confuse हो जाते हैं हम ना. So that is why I am marking it more on the right. Anybody? What is the best X-ray to detect pneumoperitoneum? The answer is chest X-ray erect. Okay, many people get confused between abdomen and chest. For pneumoperitoneum, chest X-ray is considered better than the abdomen X-ray because diaphragm is better seen on a chest plate. So when we do a chest x-ray, we are able to see gas below the diaphragm better than what we would see on a abdomen x-ray. Okay, so best x-ray for pneumoperitoneum, chest x-ray erect. Clear everybody? Monisha, are you able to understand now? Abdomen नहीं mark करना है, otherwise MCQ गलत हो जाएगा. Best, this is very frequently asked question, very frequently asked. Best x-ray to detect pneumoperitoneum is chest x-ray erect. Question number 2. But if the patient cannot become erect, then if the patient cannot stand up, what will you do? If the patient cannot stand up, we will do, tell me, left lateral decubitus. We will do left lateral decubitus. Okay. We will ask the patient to lie down on the left side. Why left side? Because when you lie down on the left side, the gas rises up, goes to the right side. But if you lie down on the right side, what will happen? Anybody can tell me. Why left lateral decubitus? Tell me. Why not right? Because if you lie down on the right side, the gas will rise up, go to the left. And on the left side, what is the problem? You have the gastric air, the fundic air, which might confuse you. That is why you need to remember, if they say best x-ray for pneumoperitoneum, mark chest x-ray erect. If they say patient cannot stand up, go for left lateral decubitus. Okay. And let me show you, some students are getting confused. ये देखो lungs देखो, a white सी line दिखेगी, that is the diaphragm. Below the diaphragm you can see the free air. Okay. Now, next question. If this is so easy, why do people get it wrong? Because the students are getting the common things wrong. I will help you to avoid that mistake. Very important question. What is the best x-ray for intestinal obstruction? You will talk about it more in surgery, but I want to tell you 3 points. What is the best x-ray for intestinal obstruction? Anybody? What is the best x-ray for intestinal obstruction? Now, this is very frequently asked and very frequently done wrong by the students. The best x-ray for intestinal obstruction is x-ray abdomen supine. X-ray abdomen supine is the best x-ray for intestinal obstruction, in which we see the distribution of dilated bowel loops. If it is small bowel obstruction, the dilated loops will be more central. If it is large bowel obstruction, it will be more peripheral. It is better seen if you do a supine x-ray of the abdomen. And you can see some of you are writing erect. That is wrong. Best x-ray, single best x-ray for intestinal obstruction is x-ray abdomen supine. Okay, clear? Because we can see the distribution of bowel gas better on a supine plate. Second question, beta. Second question. Let's see if you can answer. What is the investigation of choice for intestinal obstruction? Previous NEET question. Anybody? What is the investigation of choice for intestinal obstruction? Now, we have to understand that X-ray can only tell you if there is obstruction or not, but if we do a CCT, it can also tell us the site and cause of obstruction. So investigation of choice for intestinal obstruction is CECT. Are you clear? Investigation of choice for intestinal obstruction is a contrast enhanced CT, which can show you obstruction as well as any cause of obstruction can be picked up. Okay. Third question, beta. Third question. Along with supine X-ray, in intestinal obstruction, we also do erect X-ray. Why do you do erect X-ray? To look for air fluid levels. Can you see air fluid levels normally also? Yes, remember, up to 3 air fluid levels can be considered physiological. Okay. Now erect X-ray can only show me air fluid levels. For distribution of bowel gas, it is better to be in your physiological position, which is supine. So in the supine plate, we see the distribution of bowel gas better. Erect X-ray looks for air fluid levels. Up to 3 air fluid levels can be physiological on a X-ray. Okay. Now some bacha is saying, why not NCCT? Because CCT helps us to see if there is any malignancy or any tumor, because a cancer will pick up the dye and we are able to make a better diagnosis by looking at the contrast enhanced images, because any inflammation, any tumor will pick up the dye. Okay. Now, so sometimes they might ask you, up to how many air fluid levels can be physiological in an adult? Up to 3 air fluid levels can be physiological in an adult. Okay, clear? Now let us take it a level higher. Let me make it more complicated for you. Okay. Okay. Let's go a little bit higher, little bit complicated for you, and I will show you this X-ray. This is a supine X-ray done in an infant. Anybody can see what has happened? Okay. Now I think some बच्चा are saying से bowel distribution से क्या होगा? देखो एक बात दोबारा से देखते हैं. If it is small bowel obstruction, the dilated loops will be more central. If it is large bowel obstruction, the dilated loops will be more peripheral. Okay. Okay, somebody is saying, how can we know the cause on a CT? CT can show us if there is any hernia, internal hernia, or any tumor. CT can pick up the causes also. That is why CT is the investigation of choice. Okay. Now please see. Suppose you have bowel perforation and you are looking at an X-ray of an infant. In infant, the X-ray is supine. Why it is supine? Because in infant you cannot ask the infant to stand up to get an X-ray done. It is supine. So in supine film, what will happen? The water will settle down, the air will rise up. Okay. So what happens is, if this is your abdomen, the bowel loops, they tend to float to the center and the free air tends to rise up and collect in the periphery. So this is where you have the free air. I am again repeating. So in infants you might have heard of a condition, necrotizing enterocolitis, which leads to perforation. So suppose there is perforation in this infant and there is gas. So when the bowel perforates, fluid will also come out, air will also come out. So the fluid will settle down, the bowel loops and the viscera will float to the center, the gas will rise up and collect more in the periphery. So when we see this appearance, bowel loops and viscera in the center, air in the periphery, it is called as, anybody? Football sign. Okay. Anybody? Football sign on X-ray abdomen seen in? Again, pneumoperitoneum. It is a X-ray sign of pneumoperitoneum. Now, pneumoperitoneum has some named signs. It has some named signs. Before I go forward, I see some bacha saying, sir, bowel obstruction के लिए barium क्यों नहीं पिला देते? Now that is where I want you बच्चास to get clear on basics. अगर बेटा आप सोचो बेरियम थिक होगा, विस्कस होगा, उसको पहले अगर सपोज सब एक्यूट ऑब्स्ट्रक्शन हुआ, आपने बेरियम दे दिया, इट कन्वर्ट्स इट इनकम्प्लीट पार्शियल ऑब्स्ट्रक्शन इनटू कंप्लीट ऑब्स्ट्रक्शन. Okay, so you will avoid giving barium orally, because if you want to take the patient for surgery, then the barium will take time to clear. So you cannot give barium there, because it can get, because of obstruction, it will get stuck in the intestine and it will delay the surgery that you might have to do. Okay, now my questions are these. Anybody? Football sign is a supine X-ray sign of pneumoperitoneum. If in an infant, the infant is lying supine, so the abdominal viscera tend to float to the center, free air rises up and collects in the periphery like a football. Football sign seen in supine X-ray in pneumoperitoneum. In pneumoperitoneum, if you have air in the peritoneum, it can outline the peritoneal folds like falciform ligament. So there is a term called as falciform ligament sign. I am again repeating. What is falciform ligament? Falciform ligament is a peritoneal fold. So if you have pneumoperitoneum, air will outline the falciform ligament and make it visible. So if on the X-ray they say falciform ligament is visible, that means there is pneumoperitoneum. What is this called as? Falciform ligament sign. Only the names are important. Second question. Pneumoperitoneum can also outline the umbilical ligaments. Pneumoperitoneum can also outline the umbilical ligaments. Umbilical ligaments from the umbilicus are going like this. Okay, from the umbilicus they are going like this. So if you have gas outlining the umbilical ligaments, it is called as inverted V sign. It is called as inverted V sign. Okay, falciform ligament sign, inverted V sign. These are signs of pneumoperitoneum due to outlining of peritoneal fold ligaments by air. Okay, one more question. Let's see if you can answer. Suppose if this is your diaphragm, central tendon diaphragm. Suppose the air rises up and collects here. Suppose the air rises up and collects below the central tendon of diaphragm. To describe it, we use a term cupola sign. This is called as cupola sign. Okay. Suppose the air collects in the Morrison's pouch. Suppose the air goes into the Morrison's pouch. This is how it will look like. Suppose you have free air in the peritoneum and it collects in the Morrison's pouch. It looks like this. This is called as Doji cap sign. Doji cap sign is air in the Morrison's pouch. Okay. And suppose the air gets trapped between the 2 or 3 bowel loops. Suppose these are your bowel loops. Suppose these are your bowel loops. Suppose the air gets trapped between them. A small pocket of air is seen between them. It will appear triangular. This is called as tell-tale triangle sign. Okay, I know I will have to repeat, so I am going to go slowly and tell you again. In our books, it is only some 4 or 5 names which are written. I have tried to give you some control over them. Give some named signs of pneumoperitoneum. What are the named signs? Football sign. Second sign, bolo, falciform ligament sign. Number 3, umbilical ligament sign or the inverted V sign. Number 4, cupola sign, air below the central tendon of diaphragm. Air in the Morrison's pouch, Doji cap sign. Amrut, you are asking where is Morrison's pouch? Morrison's pouch is the hepatorenal pouch. Hepatorenal pouch between the liver and the kidney. And if you see air between the bowel loops trapped like a triangular pocket of air, tell-tale triangle sign. Tell-tale triangle sign. One more sign is left. One more sign is left. Normally, air is present inside the bowel loop. Normally, air is present inside the bowel loop, outlining the mucosal surface of the bowel. But if you have perforation, air is present both inside the bowel as well as outside the bowel because there is perforation. So you will see air outlining both the inner and outer walls of the bowel wall. I will write down, don't worry. If you see air outlining both inner and outer bowel wall, that means there is perforation. This is called as Wriggler's sign. This is called as Wriggler's sign. So what is regular sign? What is regular sign? Air outlining. Please see with me. This is a bowel loop. You can see the inner side, which is the mucosal side, as well as the outer side, because air is present on both the sides. If air is present on both inner and outer aspect of the bowel wall, it is called as regular sign of pneumoperitoneum. Regular sign of pneumoperitoneum. Now, if it is easy, why do students get confused? Students get confused because there is something else which is called as regular triad. Now, if you want to win a prize from me, let me know in the chat box where in your surgery class the teacher was telling you regular triad. बोलो सर्जरी में रेगुलर ट्रायड कहां था? Regular triad is the X-ray feature of gallstone ileus. I think Shri Manojana Reddy got it right first, and Ramcharan. It is a X-ray sign of gallstone ileus. 1, 2, 3. What are these? If you have air in the biliary tree, pneumobilia, small bowel obstruction, visible gallstone. Okay. Gallstone ileus on X-ray is identified if you see the regular triad, which includes pneumobilia, small bowel obstruction, and radio-opaque gallstone. Together, this is called as regular triad. तो triad अलग है, regular sign अलग है. Regular sign is sign of pneumoperitoneum. Okay, clear? Now I will give you a image, two tricky images to solve. Okay, I am giving you a CT image to look at, and anybody in the chat box can answer and tell me where is the problem. This is your liver, aorta, IVC. I am zooming in. Just see, superior mesenteric artery, superior mesenteric artery, superior mesenteric vein, right kidney, left kidney, vertebra. Now along the aorta, if you notice, around the aorta, if you notice these muscular slips, these are your diaphragmatic crusts. These are your diaphragmatic crusts. These are the crura of diaphragm, if you see them here. This is aorta. This is inferior vena cava, superior mesenteric artery. This is your left renal vein passing between the aorta and the superior mesenteric artery, superior mesenteric vein, inferior vena cava, right kidney, liver. Everybody clear? So, but these are all normal structures. The problem is here. What is this? Anybody? Were you able to pick up? What is this? When we do a CT scan, the patient is lying supine. So if you have perforation or pneumoperitoneum, air rises up and collects below the anterior abdominal wall. What is your diagnosis? Pneumoperitoneum. This is pneumoperitoneum on a CT scan. So many times they have shown you X-ray. Many times this X-ray has been asked in the exam, gas below the diaphragm. So I feel that in the next exam, they might just show you a CT showing you pneumoperitoneum, and you should be able to pick up. Okay. Now, next question coming your way. Anybody? Let me ask you a question. A patient comes to you with abdominal pain and you are the doctor on duty. Very important question. Patient comes to you with abdominal pain. You are the doctor on duty. Do you think there is perforation or not? Okay. Do you think there is perforation or not? Yes or no? Perforation है कि नहीं है इसको बोलो. आप वहां पे डॉक्टर है. आंसर है नहीं है. बताओ क्यों? Because this area is actually showing Haustrae. So this is not free air. In this patient, we can see part of the colon interposing between liver and diaphragm. So this is not free air. This is the colonic loop which is between liver and diaphragm. This is called as Chilaiditi syndrome, or we can use the word pseudo pneumoperitoneum. We can use the word pseudo pneumoperitoneum. Everybody clear? So this is how they will confuse you in the exam. You will say gas below the diaphragm, but please see, this is continuing with the colonic loop. It has folds or haustray inside. It is colon which has gone between the liver and diaphragm. It is an anatomical variant. It is nothing but a anatomical variant. It is nothing but a anatomical variant. This is called as Chilaiditi syndrome. Everybody clear? Okay. I will ask you more questions then, because I can see you are all very, very bright children, and I've already told you, I think you are the best batch that I have ever taught in my life. You are so intelligent, you know. Now tell me, anybody can answer this picture now. Let us see some normal anatomy more. Let us try to identify normal structures. This is a CT abdomen. This is your liver. This structure is your gallbladder. Are you able to see a fluid filled structure along the liver here? This is your gallbladder. This is your gallbladder. This is your left kidney. This is your spleen. Okay. Aorta, inferior vena cava, tail of pancreas, body of pancreas. You can see the tail and the body of pancreas. Okay. Now, question here is, okay, some बच्चा is saying, sir, अगर वो चिलाइडिटी है तो उसको abdominal pain क्यों हुआ? So abdominal pain can occur. Mary can be, sometimes even, we also get it, but sometimes it may not be perforation. So that is why it is important for the X-ray person to identify clearly. Okay. Okay. Now look at this. Okay, I'm repeating. Left kidney, spleen, tail of pancreas. In relation to the spleen, you have the tail of pancreas, body of pancreas. Head is not seen. Head is not seen because pancreas is like this. Tail is higher up, head is lower down. So head will be seen in the lower cut. Inferior vena cava, aorta, liver, gallbladder. From the, everybody listen to me, from the aorta at this level, a artery is arising. Anybody can tell me which artery would be this? At the level of the tail of pancreas, at the level of the spleen. What is this? This is your celiac trunk, dividing into the common hepatic and the splenic artery. This is your celiac trunk, celiac artery. Okay. Some बच्चे is saying, sir, right kidney क्यों नहीं दिख रहा? Right kidney थोड़ा सा नीचे होता है, left kidney थोड़ा ऊपर होता है. Left kidney is higher than the right. So when we go further down, you will see the other kidney. Okay. Now, my questions are these. I am going to give you a question which will win you a prize if you answer this. Okay. Identify this structure here. Can you identify this yellow marked structure? I have marked a structure with a yellow color, anterior to the left kidney and superior to the right kidney here. Can you see? What could be this structure? Arrowhead-like structure, slightly anterior to the left kidney and superior to the right kidney. What could this be? This is the location of your adrenal glands, adrenal or suprarenal glands. This is where you have your adrenals or suprarenal glands. Okay. Now, why is all this important? Suppose they show you a tumor sitting here. Suppose you are sitting in your USMLE exam thinking that America hai, hi-fi पूछेंगे and all those things. You're worried about the exam. Suppose, you're giving a USMLE exam and they show you a tumor sitting here, separate from the kidney. Suppose you have a tumor here and they say patient has paroxysmal hypertension. Paroxysmal hypertension and the patient has this on a CT scan. What could it be? Now you know this is the kidney. Left kidney slightly anterior to it you have the adrenal. This must be adrenal tumor. Then you think of pheochromocytomas. Are you clear? But if you don't know the anatomy, you will struggle. Okay, the most important message that I want you to know from my classes is that it is always about connecting the dots. If you notice that in my entire class, I have never talked about radiology. I am actually connecting radiology to other subjects so that you are able to get a 360 perspective. And that is what is required for your exams and also for your real life also. You need to connect the dots. Okay. So for Dipankar, I am showing you the suprarenal once more. This is your adrenal gland. Okay, maybe we can use a yellow color to make it more visible. Adrenal gland. Okay, and one bacha, Anamika is saying, sir, celiac artery bhi dikha do. Ye beta, ye celiac artery. Let me just paint celiac artery slightly for you so that it becomes more visible. This is how the celiac artery would be. Ventral branch from the aorta, dividing into the common hepatic and the splenic artery. नाउ वन बच्चा कह रहा है सर एड्रीनल किडनी के एंटीरियर क्यों है लहरी? ऐसा ही होता है, ऐसा ही होता है. राइट एड्रीनल इज सुपीरियर टू द किडनी, left adrenal is slightly anterior. This is how the anatomy is. If you go back and revise, you will find it exactly in the same manner. Okay, okay, Dr. Lahiri, you understand now that you are saying sir adrenal superior होता है. ये आपकी ignorance है, इसलिए आप ऐसा कह रहे हैं. Right adrenal is above the kidney, left adrenal is slightly anterior to the kidney. When you go back and read, you will realize that every day of your life as a doctor will be a humbling experience. Humbling मतलब आपको लगेगा कि सब आ गया है, अगले दिन पता चलेगा नहीं आया है और सीखने की जरूरत है. ओके ओके, क्लियर बेटा? Every day as a doctor will be a humbling experience. Every day you think that you can win against death, you can improve, you can save everybody, but it will be humbling experience. You will not be able to do it. We cannot become gods. That is why it is important as a doctor to stay humble, keep learning, keep learning. Okay, now once you have learned all this, this is normal anatomy. Let us look at a case which is very often asked as a CT image in your exam. All of you beta, all of you look at this image. All of you look at this image. This is your liver. This is your gallbladder. Right kidney, left kidney, aorta, inferior vena cava, stomach. Okay, anybody can tell me what organ, anybody can name what organ is diseased? Okay, what organ is having the disease? Now some bachas are saying कि सर हम थक गए हैं, but I want you to know ऐसा हो सकता है that when you are sitting in your emergency and you are tired but somebody is dying. Now try to understand, this is something that I see a lot of doctors are unable to understand. He is saying sir it is night, I am tired but somebody is dying. किसकी प्रॉब्लम ज्यादा बड़ी है? Now you have to not diagnose. Even if you're tired you have to diagnose. Tell me beta, it is pancreas which is having the problem. Pancreas is swollen, swollen. In this patient, the pancreas is swollen. Anytime I see a organ swollen, I always think of acute inflammation. So I'm thinking of acute pancreatitis. Acute pancreatitis. Now, immediately in my mind, there is a question. A very important question I want all of you to answer. I want all of you to look at the screen and answer, beta. This is the normal appearance of pancreas, and the other part that I see here is non-enhancing. I want all of you to see this. एक बार इसको देखना बेटा. Okay, some बच्चा is saying sir ये liver के ऊपर white spots क्या दिख रहे हैं? These are your rib cage, ribs है. These are ribs. Okay, now clear? अब बेटा देखो. Why is this area not taking up the dye? Why is this area not enhancing? I have given intravenous dye. I can see the dye in the blood vessels. Why is the pancreatic parenchyma in this particular case not enhancing? Bolo? Anybody? Because of necrosis. That means this is necrotizing pancreatitis. Necrosis will be non-enhancing. It is dead tissue, necrotic tissue. Clear? Okay, everybody understands? Now वन बच्चा कह रहा है सर ये राइट किडनी छोटी क्यों है, लेफ्ट बड़ी क्यों है? बिकॉज लेफ्ट किडनी हायर होता है, तो ये लेफ्ट किडनी का सेंटर है और उसका अपर पोल है. I hope you understand that kidneys are not exactly symmetrical in our body. One kidney is higher, one is lower. So we are cutting through the middle of the left kidney, but it is the upper pole of the right kidney. इसलिए थोड़ा asymmetric लग रहा है. Okay, Jaisal Gaurav, you understand now? Okay. So can you now understand why people are doing mistakes? Because you are not thorough on anatomy, not about radiology. Okay, so that is why people will look at it, say kidney का problem, question pancreatitis है, exam में rank पीछे हो गया. Okay, now I am going to repeat. I am going to repeat for you the clear thing. Okay, why now? I think you know most of the questions we have seen. Let us understand what is the investigation of choice for acute pancreatitis. CCT. Investigation of choice for acute pancreatitis. CCT. CCT. Okay. Now my questions are these. Let's see how many of you can answer this question. I'm asking you some questions. Listen to me beta. Question सुनो पहले मेरा. Question है, to diagnose acute pancreatitis, any two of the following if present, we will call it acute pancreatitis. Severe epigastric pain, severe epigastric pain, okay, elevated amylase lipase, elevated enzymes, radiological evidence. Okay, I'm repeating beta. सुनो मेरी बात को सुनना है आपने. Any two of these if present, we can make a diagnosis of acute pancreatitis, severe epigastric pain, elevated enzymes and radiological evidence. Now on the basis of this, solve this previous AIMS question. CCT is essential to make the diagnosis of acute pancreatitis. True या false? CCT is essential to make the diagnosis of acute pancreatitis. True या false? True या false? Anybody? It is false. Why? Because even if you don't have radiological evidence, still you can diagnose pancreatitis clinically if you have severe epigastric pain and elevated enzymes. So CT is not essential for diagnosis. So what is the role of CCT in pancreatitis? The main role is to assess severity. Main role is to assess severity. So to assess severity, we should do CT at least 72 hours after presentation. Okay. Very, very important. You will not do CT immediately at presentation. You will do it 72 hours later. Because if you do too early, you might underestimate or overestimate the necrosis. You might confuse edema and necrosis if you do it too early. If you do the CT too early, you will confuse necrosis and edema. That is why you should do it after 72 hours for severity. And how will you know severity? How will you know severity? We will use something on CT which is called as modified CT severity index. We will calculate a score which is called as modified CT severity index based on degree of necrosis, amount of inflammation and any extra pancreatic complication present or not. I will again repeat beta, don't worry if you are not able to write down. Sometimes they might say, okay, sometimes they might say, what is the, okay, everybody tell me, modified CT severity index based on degree of necrosis, amount of inflammation and presence of extra pancreatic complications. Okay, if the CT is done early, you may not be able to differentiate edema from necrosis. So you may not be able to you may not be able to assess the severity correctly. Okay, Sakshi? Okay, so this is how the role of CT in pancreatitis. Now CT can tell me necrosis. CT can tell me necrosis because necrosis will be non-enhancing. Now if you are able to understand so far, I want you to see and tell me if you are able to answer this very small question. If I ask you, this is your pancreas, this is your pancreas, okay, pancreas, this is your descending colon, ascending colon will be somewhere here maybe, okay. Now anybody, if you remember from your anatomy, pancreas and colon are ascending colon and descending colon are in the same anatomical space called as pararenal space. I am sure you know this. Ascending colon, descending colon are retroperitoneal, pancreas is retroperitoneal, so they are in the anterior pararenal space. So inflammation present in the pancreas will go to the descending colon and it will cause spasm of descending colon. So if you look at the X-ray of the patient with pancreatitis, you will see gas in the colon and then you will see cutoff. I am repeating beta. I am दोबारा से बता रहा हूँ. Okay, everybody. I am again repeating. Colon cutoff sign is seen on X-ray in. Answer is acute pancreatitis, because if there is inflammation in the pancreas, it can spread to the descending colon. It will cause spasm of the descending colon, and you will see a cutoff at that level. Colon cutoff sign on X-ray is seen in. The answer is acute pancreatitis. Colon cutoff sign. Everybody understands? Okay. Now to solve one doubt that one bacha is again and asking कि sir chronic कैसे पता चलेगा, chronic क्यों नहीं है? I will show you chronic beta. Okay. So all of you see this X-ray and then we will discuss. Liver, gallbladder, colon, aorta, inferior vena cava, right kidney, left kidney, portal vein. Okay, now I have labeled the structures for you. Please look at the CT and tell me which organ is having the disease. What is this organ? Pancreas. Now look at the size of pancreas and tell me, is it normal, enlarged or shrunken? This pancreas is shrinking. It is becoming thin. Why? Because of fibrosis. Why would fibrosis happen? Why would fibrosis happen? Because of chronic inflammation. And the disease is so chronic that you can see calcification also there. What is your diagnosis? This is chronic pancreatitis. Chronic pancreatitis on a CT scan. Because the pancreas is shrunken and calcified. This is chronic pancreatitis. Quick 2 questions for you. Investigation of choice for chronic pancreatitis is. Investigation of choice for chronic pancreatitis is MRCP with secretin. Please mark this in the exam. Investigation of choice for chronic pancreatitis is MRCP with secretin. That means you do MRCP after giving secretin. What will you see? You will see that the pancreatic duct will have fibrosis, dilatation, fibrosis, stricture, dilatation, stricture, dilatation, stricture, dilatation. Can anybody give me a name and tell me what is the sign called as? This is called as chain of lakes appearance of the pancreatic duct. Multiple strictures, alternate dilatation and strictures is seen in chronic pancreatitis. Okay, next question beta. Next question, anybody. If MRCP is not given in the choice and they ask you investigation of choice, you can go for CCT. Investigation of choice for chronic pancreatitis, MRCP with secretin. Not given in the choice, go for CECT. If they say best investigation for chronic pancreatitis, you can mark endoscopic ultrasound. Best investigation for chronic pancreatitis, the gold standard investigation is endoscopic ultrasound. Endoscopic ultrasound. Okay. दीपंकर इज सेइंग सर वो हमें कोलन कट ऑफ क्यों मिला था? देखो, descending colon and pancreas, both of them are in the anterior pararenal space in the retroperitoneum. They are in the same retroperitoneal compartment. So inflammation happening in the pancreas will also cause inflammation and spasm of the descending colon. So on the X-ray you will see gas in the transverse colon, then there will be no gas in the descending colon because that is in spasm. That is called as colon cutoff sign. Okay, Dipankar and Soumyadeep Pal. Okay, now if you have understood so far, what I will do is I will also show you one more image and maybe one more question. Okay, anybody now tell me, if the pancreas is swollen like a sausage shaped pancreas, what will you suspect? Pancreas is swollen, but it is swollen more like a sausage. Then what will you think? Anybody? Anybody? Can you answer? Sausage shaped pancreas seen in autoimmune pancreatitis. Very important Central Institute level question. Autoimmune pancreatitis. Pancreas is sausage shaped, IgG4 related disease. So remember, usual causes of pancreatitis are alcoholism and gallstone disease, but some patients may have rare cause of pancreatitis. It could be autoimmune. So autoimmune pancreatitis is IgG4 related disease, sausage shaped pancreas. My question to you is this, beta, anybody, did I mention IgG4 related disease anywhere else in my class? Did I tell you IgG4 anywhere else in my class? IgG4 was also mentioned in retroperitoneal fibrosis yesterday. Okay. Now, another rare cause of pancreatitis is biliary microlithiasis. That means, suppose you have tiny stones in the bile which are not seen on abdominal ultrasound, but when you see them later on in the autopsy, you see tiny stones. So bile having micro stones, small, these can be seen on endoscopic ultrasound. Another cause, rare cause of pancreatitis is pancreatic divisum, a ductal abnormality where you have a divided pancreatic draining system. You have two separate pancreatic ducts which can be diagnosed on MRCP. Okay, so I'll just complete this by writing two words here: alcohol, gallstones. So whenever we see pancreatitis, usual causes are alcoholism, gallstones. But there can be rare causes like autoimmune phenomena where you will have sausage shaped pancreas. You can have biliary microlithiasis, which will be seen on endoscopic ultrasound. You can have a ductal embryological abnormality called as divisum, where MRCP is the investigation of choice. Okay, everybody gets it? Now, before we give you the break that you are asking for, we will have to look at one more image and then I will give you the break. Okay, one more image and then I will give you the break. Okay, liver, portal vein, spleen, stomach. We have given oral contrast also, so you can see some dye in the stomach. Aorta. Okay, everybody now please look at the screen. Please look at the screen and tell me. Okay, Please look at the screen and tell me, anybody, where is the problem located? Where is the problem located? Okay. Now, Gomati is saying, sir, chronic pancreatitis mein endoscopic ultrasound, how does it help? Endoscopic ultrasound helps in looking at both parenchymal changes as well as ductal changes. So it is considered superior to MRCP. Okay. Now, anybody now, where is the problem? The problem is here. Behind the stomach, posterior to stomach, you have a well walled off fluid collection, medial to the spleen, behind the stomach, this is the area. This is where you have your lesser sac. If you remember, the peritoneum has the greater sac, lesser sac. This is where you have the lesser sac, well walled off fluid collection. It could be a pancreatic pseudocyst. It could be a pancreatic pseudocyst. Clear? It is possible that it could be a pseudocyst. My question to you is this. Let's see, any one of you can answer. Are you aware of the nomenclature that we use nowadays for pseudocyst? We use a nomenclature which is called as Atlanta nomenclature. Atlanta nomenclature says there are two types of pancreatitis, edematous and necrotizing. How will you differentiate? Necrotizing will have non-enhancing areas. It will not take up the dye. So there are two types of pancreatitis, edematous and necrotizing. If you see a fluid collection in edematous pancreatitis less than 4 weeks duration, that means the duration of the disease is less than 4 weeks, what will you call it? Okay, Manoj, Shubham is saying, Ankita is saying कि सर्जरी में पड़ा है, तो अब बता दो फिर. ओके, तो बताओ ना बेटा, पूछ तो रहा हूं ना मैं, बोलो तो. If in a patient with edematous pancreatitis, you see, if in the case of edematous pancreatitis, you see fluid collection less than 4 weeks, what is this called as? It is called as acute peripancreatic collection. APC. It is called as APC, acute peripancreatic collection. Very good, beta. Dusra, if the fluid collection is seen after more than 4 weeks in edematous pancreatitis, then we use the term pseudocyst. Then it is called as pseudocyst. Clear? If you see fluid collection after more than 4 weeks, then it is pseudocyst. But remember, in necrotizing pancreatitis, less than 4 weeks, it is called as acute necrotic collection. More than 4 weeks, it is called as walled off necrosis. More than 4 weeks, it is called as walled off necrosis. Clear? Possible questions can be asked. Don't get confused in the exam. Now, because you are able to answer this and you are so confident, I will now take you to the next level of question here. On the same topic, I will give you one difficult question, beta. Suppose, let's see if you can answer this. Let's see how many of you are ready for the AIMS exam. On your marks, tell me, a middle-aged lady has a unicystic lesion in the pancreas, single cystic lesion in the pancreas, no history of trauma, no history of pancreatitis. What should you suspect? चलो अगला लेवल पे क्वेश्चन आ गया. देखिए आप में से कौन बताता है. Anybody now? Tell me. A middle-aged woman, lady, has a unicystic, single cystic lesion in the pancreas, no trauma, no pancreatitis. If there is no trauma, no history of pancreatitis, we are trying to rule out pseudocyst. Pseudocyst will happen after pancreatitis, after trauma. Hai nahi? And this is a female patient. Now the key word for all of you to remember is, women are prone to develop cystic neoplasms in the pancreas. This is the classic description of, anybody now solve it? Mucinous cystic neoplasm of the pancreas. Mucinous cystic neoplasm of the pancreas. Why it is not pseudocyst, Sumatra? Because there is no trauma, no pancreatitis. And they have mentioned female patient, they are not saying alcoholic, they are not giving any other clue. Okay, I will now make it more difficult now. Let's see how many of you can answer this. An old lady has multicystic lesion in the pancreas with a central stellate sunburst scar. What will you suspect? Now suppose they say an old lady, now the lady is grandmother age group, old lady, multicystic lesion, central scar, what will you think? This is where you will think of serous cystadenomas of the pancreas, which are usually benign tumors. Serous cystadenomas are benign. Mucinous cystic neoplasms have malignant potential. Serous cystadenomas are benign. Okay, these are multicystic, they have a central scar. Can you also recall in which conditions do we see central scar? One is serous cystadenoma. Any other tumor that you might have studied in surgery which have a central scar? Central scar in the liver is seen in a benign lesion called as focal nodular hyperplasia, and in kidney in a tumor called as oncocytoma of the kidney. Okay, so tumors which have a central scar, pancreas में serous cystadenoma, liver में FNH, focal nodular hyperplasia, kidney में oncocytoma. Okay, are you able to answer this much? Okay, one more question. Now AIMS level question coming your way, then we will think of a break. One more tough question, beta. Male patient or female, both is possible, male equal to female. Multicystic lesion in the pancreas on a CT scan appears to communicate with the pancreatic duct. Appears to communicate with the pancreatic duct. Anybody now tell me? A multicystic lesion in the pancreas, male, female, same ratio in male and female, other two were common in females, communicating with the pancreatic duct. What will you suspect? This is the typical description of IPMN. What is IPMN? Intraductal papillary mucinous neoplasm. Intraductal papillary mucinous neoplasm. And because it is a mucinous tumor, if you do a endoscopy, the ampulla of Vater will be distended with mucus, and we see something called as fish mouth ampulla on ERCP. In this particular condition, if you do a ERCP or endoscopy, you will see a fish mouth appearance of ampulla. This is intraductal papillary mucinous neoplasm. Male is equal to female. Okay, but the key word is communicating with the pancreatic duct. Keyword is communicating with the pancreatic duct. Okay, clear everybody? Okay. So what I have done here is, if you notice, how I have gone about, we started with the esophagus problem, stomach problem, perforation, X-ray of perforation, X-ray of chiladity, supine signs, how to look at X-ray of obstruction. Then we went on to see the pancreas, pancreatitis, acute, chronic, pseudocyst, cystic lesions, and I have covered the ground for pancreas. Okay. Okay, Sindhu is saying, sir, oncocytoma kya tha? Oncocytoma, Sindhu, Arungari, oncocytoma is a kidney tumor which has a central scar. Okay, kidney tumor with a central scar. Okay, so in our abdomen there are three important tumors which have a central scar. serous cyst adenoma of the pancreas, focal nodular hyperplasia FNH in the liver, and oncocytoma of the kidney. These are three important tumors which have a central scar. Further, more organs and more diseases. And you might have seen that we started from the esophagus, saw the stomach, pancreas. Now we will look at liver. Now, when I will now show you liver, okay, Jitendra is saying is a colon cutoff में stenosis. Stenosis नहीं बेटा, spasm है. Jitendra, there is spasm because of the inflammation. Okay. Now I will teach you a investigation in the liver which is called as triple phase CT. Just like in pancreas, you have a triple phase CT where we look at the tumor of the pancreas in multiple phases. Although you don't need to learn it, but liver triple phase CT we need to know in more detail. This is a triple phase CT in front of you, which is the investigation of choice for hepatocellular cancer. Hepatocellular cancer. Everybody remembers? Investigation of choice for hepatocellular cancer, triple phase CT. But if they change the question, and they say screening for HCC in patients with cirrhosis should be done with, if a patient has cirrhosis and you want to do screening for HCC, how will you do it? Anybody? You will do a 6-monthly ultrasound to look for any tumor or nodule. Okay. So these are two very important questions. Many people get it wrong in the exam. I again want you to know, investigation of choice for HCC triple phase CT, screening for cirrhosis is done with screening for HCC in patients with cirrhosis is done with ultrasound. Clear? Okay. I think most of you are already aware of it. So let's go deeper into it. Okay. The logic behind the triple phase CT and radiology of liver is, please see with me, liver has dual blood supply. Can you name the sources of blood supply in the liver? It has dual blood supply, mainly supplied by portal vein, also supplied by hepatic artery. Okay. Now I think one बच्चा is getting confused. आशुतोष चौहान, देखो बच्चा, आशुतोष सुनो एक बार, आदित्य आप भी सुनो. अगर किसी को cirrhosis है, cirrhosis is a risk factor for developing hepatocellular cancer. So in these people, every 6 months we do a screening ultrasound to see if there is any tumor. Okay. So liver has dual blood supply, mainly by portal vein but also by hepatic artery. What is the blood supply of hepatocellular cancer? What is the blood supply of liver metastasis? Both the hepatocellular cancer and metastasis are supplied mainly by hepatic artery, but the normal liver parenchyma by mainly by portal vein, while tumors in the liver are mainly supplied by hepatic artery. The difference is hepatocellular cancer is a hypervascular tumor. Metastasis typically in the liver are most commonly from the colorectal cancers. Colorectal cancers are hypovascular. Okay. Should I repeat? I am repeating for you. Okay. This is the physiological reason behind what we will do in radiology. Liver is mainly supplied by portal vein, but the liver cancers are supplied by hepatic artery. Hepatocellular cancer is hypervascular, colorectal metastasis are hypovascular. So how do we do, okay, how do we do the triple phase CT? We give IV contrast injection. After 25 to 35 seconds, we do the CT scan of the liver. After injection, we wait for 25 to 35 seconds and we do the CT of the liver. This is called as hepatic arterial phase. Hepatic arterial phase, or we can call this as late arterial phase, same thing. Okay, should I repeat? Are you clear, beta? After giving IV contrast, we do the CT of the liver at 25 to 35 seconds. That is the late arterial phase, or we say hepatic arterial phase, short form HAP. Then we do the CT of the liver at 60 to 70 seconds, which is called as the portal venous phase. Then we repeat the CT at 5 to 10 minutes, which is called as the equilibrium phase. Okay, everybody listen to me and answer. So name 3 phases of triple phase CT of the liver. What are the 3 phases of triple phase CT of the liver? Anybody? Hepatic arterial phase or late arterial phase, whatever they write. Portal venous phase, equilibrium phase. Okay. Now the liver CT arterial phase can be divided into early and late, Muskan Agarwal, and liver CT is typically done in late arterial phase. So you can remember this. This can help you in a tough MCQ later on. Okay. Are you clear? This is called as the triple phase CT of the liver. Now, for the students who want to get into central institutes and want to solve tough question also, there is something called as 4-phase MRI of the liver, in which in addition to these 3 phases, there is a 4th hepatobiliary phase also, which is seen if we use a special dye for liver, which is called as gadolinium. Okay. Now I am again repeating. So this is only needed for the usual MCQs. This is for maybe for the INI CT exam. That liver CT is triple phase CT, but nowadays we can do a 4-phase liver MRI, where the 4th phase is called as hepatobiliary phase, and the dye which is used for that purpose is called as gadolinium gadolinium. Okay. Now, so once we have clear, now the physiology that we have learned is HCC is hypervascular, liver metastases are from colorectal cancer usually, and they are usually hypovascular. Both of them are supplied by hepatic artery. Now, can you understand now that hepatocellular cancer will be seen better in the arterial phase because it is supplied by the artery and it is hypervascular. Colorectal cancers are supplied by the hepatic artery, but they are hypovascular in nature. They don't have much vascularity. So they will be seen as darker areas in portal venous phase. Okay. Now let me just make it again for you. राजकुमार एक बार समझते हैं. देखो, when we say triple phase CT, it means we are doing the CT at different time intervals of contrast injection. We give IV contrast, we take the CT in the arterial phase, again take the CT in the venous phase, then in the equilibrium phase. Okay. Now, question here is only this. Let's try to understand the concept. Okay. I'll try to make sure that you understand the concept. Otherwise, it will be tough, but I want you to focus on the screen and try to understand. This is an image showing you the triple phase CT of the liver. I'm zooming in for you, beta. I'm zooming in for you. This is your liver, stomach, spleen, aorta. Okay. Now the first image is a non-contrast CT of the abdomen. We cannot see the tumor in the non-contrast CT because it is made up of liver cells. It is hepatocellular cancer. So it is similar to liver parenchyma and we cannot differentiate between them. We cannot differentiate. So we cannot see any tumor in the liver. But, okay, but what we are able to see is some nodularity. We can see some nodularity. Okay, we can see some nodularity on the liver surface. Anybody? If the liver surface is nodular, what will you think? If the liver surface is nodular, we will think of cirrhosis. Okay. If the liver surface is nodular, we will think of cirrhosis. Let's do a triple phase CT. Let us do the scan at the arterial phase. How do we know it is the arterial phase? The dye is in aorta, not yet reached the veins. It is mainly in the aorta. The veins are not visible. Okay. So if the dye is in the artery and the veins are not visible, that means this is the arterial phase. In the arterial phase, are you able to appreciate the tumor? Are you able to appreciate the tumor? Yes. How will we describe? We will say there is enhancement in the hepatic arterial phase. This tells you that you are dealing with a hypervascular lesion supplied by hepatic artery because it is showing enhancement in the arterial phase. Now we will do the CT again after 60 to 70 seconds to see the portal phase. In portal venous phase, you can see the dye in the aorta, but you can see the dye in the veins also. You can see the dye in the portal vein, dye in the vessels. So this is the venous phase. In the portal venous phase, the dye is now in the portal vein and it will cause enhancement of the entire liver parenchyma because liver parenchyma is supplied by portal vein. So in the portal venous phase, the liver parenchyma will enhance, but tumor will not receive any more dye. Tumor receives dye only in the arterial phase. So you cannot appreciate the tumor in the portal venous phase. This is called as washout. Tumor has washed out. You cannot see it. Tumor, hepatocellular cancer, is known to have a capsule around it. This capsule will retain the dye for long period. So when we do a CT in the equilibrium phase, we are able to see, if you do the CT in the equilibrium phase, we are able to see a thin white capsule around the nodule. This is called as the capsule. Okay. The tumor becomes dark in the equilibrium phase. Only the periphery remains slightly more bright, slightly more white. That is called as the capsule. So what I'm trying to say is, okay, what I'm trying to say is that HCC on triple phase CT shows enhancement in the hepatic arterial phase, washout in the portal venous phase, capsule in the equilibrium phase. Okay, are you clear बेटा? मैं दोबारा से बता रहा हूं, एक बार देख लो. So hepatocellular cancer has three phases. This is the appearance of HCC. So because it is supplied by artery, it is hypervascular, so the enhancement will be in the arterial phase. In the portal venous phase, the normal liver parenchyma will enhance. Tumor will no longer get any dye, it will show washout. In the equilibrium phase, you will see capsule. Are you able to remember this? So this is the appearance of HCC on our triple phase CT. Now because this triple phase CT is telling us that HCC is supplied by hepatic artery. So if I put a catheter in the artery, and can I put a radioisotope directly through the artery into the tumor? This is called as TAR. In hepatocellular cancer, because the tumor is supplied by the artery, if you catheterize the hepatic artery and put the isotope directly into the tumor, it is called as transarterial radioembolization, and the isotope used is yttrium 90. The isotope used is yttrium 90. Okay. Now the tumor will show washout. Harshit and Trisha, tumor will show washout because the dye is received by the tumor only in the arterial phase. So अभी कभी भी आर्टरी से डाई आएगी तो वेन वो चली जाएगी ना, उसके बाद तो वो डाई उसमें से वॉश हो जाएगी. दैट इज व्हाट यू सी इन द वीनस फेज. Are you able to understand this? That the tumor is taking up the dye only in the arterial phase. In the portal venous phase, it is showing washout. In the equilibrium phase, only the capsule shows some dye uptake because 5 to 10 minutes have passed. The dye has washed out from the liver parenchyma also, from the tumor also. Only the capsule is seen. Okay. Somebody is saying, what are the three dots in the portal venous phase? So this is your aorta, inferior vena cava. This is your portal vein. Okay. Now what was TAR? Transarterial radioembolization of hepatocellular cancer is done with yttrium 90, which produces beta rays. You can directly via the arterial route put this isotope into hepatocellular cancer. It will produce beta rays and destroy the tumor. Okay. Transarterial is done through the catheter. You are putting a catheter into the artery, femoral artery, aorta, take to the hepatic artery, and then inject the isotope into the tumor directly. Okay. Y over is not right. Okay. Okay. Clear? Now, one bacha is saying, sir, hepatocellular cancer radio resistant. That is why we are trying to put the isotope directly into the tumor so that at least we can have some damage to the tumor. HCC has a very poor prognosis otherwise. Okay. Now tell me, how will you make a diagnosis of HCC on a CT scan? We use a criteria called as LIRADS. What is LIRADS? Liver Imaging Reporting and Data System. Okay. What is TAR? TAR is a treatment method. TAR is a treatment method. I told you it is one of the treatment methods which we try because it has poor prognosis. You can put radioisotope directly into the cancer through arterial route. Transarterial radioembolization. Okay. So how will you diagnose hepatocellular cancer on CT? We use a criteria called as LIRADS. What are the criteria? Hepatic arterial phase enhancement. If a tumor shows hepatic arterial phase enhancement, washout in the portal venous phase, capsule in the equilibrium phase, more than equal to 50% serial growth in less than equal to 6 months. These are the four major criteria to call a liver lesion as HCC. So what are the four things that you want to see? If there is hepatic arterial phase enhancement, washout, capsule, more than 50% serial growth in less than equal to 6 months, we will call it as hepatocellular cancer. What are these? These are LIRADS criteria of hepatocellular cancer. And this is done by intervention radiologist. Yes, Nikhil has picked it up correctly. Now Mayuri is saying, sir, metastasis kaisa dikhega? So let me answer that question with the image. Now I want you to see, this is your aorta, portal vein, right branch, left branch, you can see the portal vein, spleen. Okay. Now please see. My question to you is this. Also, you can see the IVC also. The dye has reached the veins. You can see the dye in the veins. So when the dye has reached the veins, it will supply the liver parenchyma. But there are multiple lesions in both the lobes of liver, randomly distributed, which are not taking up the dye. Why? Because they are not supplied by portal vein and they are hypovascular otherwise. What are these? These are metastasis. These are liver metastasis. Okay. Anybody liver metastasis? Anybody? Mostly from colorectal cancer. And it is hypovascular. That means metastases are better picked up in portal venous phase. Hepatocellular cancer is better picked up in arterial phase. Can you have a hypervascular metastasis? Can you have a cancer which causes hypervascular metastasis? Carcinoid. Carcinoid is the classic cause of hypervascular liver metastasis. One बच्चा is saying serial growth. Serial growth मतलब कि आज सीटी किया फिर दोबारा किया तो वो बढ़ गया, बड़ा हो गया. मतलब serial growth means I am following up in different dates to follow up. Okay. Hepatocellular cancer, Rakesh Chaudhary, is a primary cancer. These are metastatic. Metastatic मतलब वो बाहर से लिवर में आए. हेपाटोसेलुलर कैंसर लिवर का ही अपना कैंसर है. ओके. ओके. नाउ सी, स्नेहलता इज पूछ रही है कि सर वाई कैप्सूल इज नॉट रिटेनिंग डाई इन द पोर्टल वेनस फेज. कैप्सूल इज रिटेनिंग डाई इन द पोर्टल वेनस फेज, but the problem is liver parenchyma is also having dye, so we are not able to appreciate it. In the equilibrium phase, the tumor also has the washout. Even the liver parenchyma has dye has gone. It is now washed out. There are 10 minutes later we are looking at the CT. Only the capsule will be visible in the equilibrium phase. Okay. And Trisha, I am again repeating for you. TAR is trans-arterial radioembolization, where we are putting yttrium 90 into the HCC directly into the via the arterial route. And Devraj, I am telling you, these dark areas are liver metastasis. They are hypovascular, so they don't have much vascularity, so they are not taking up the dye. But the liver is taking up the dye because it is supplied by the portal vein, so you are easily able to appreciate them as darker areas. Okay. श्रेया पॉल सिंह की कार्सिनॉइड आर्टीरियल फेज में दिखेगा. करेक्ट, करेक्ट. कार्सिनॉइड विल बी सीन इन द आर्टीरियल फेज बिकॉज इट इज हाइपरवैस्कुलर. Is Robin is saying, sir, is TAR a treatment? Yes, TAR is a treatment method. Is this a CCT image? Yes, we have given intravenous contrast. Okay, clear, Magesh? Okay, Devanshi, this is portal venous phase. Portal venous phase. What is the structure anterior to the spleen? I think she is asking this structure and this structure. This is your stomach. This is your splenic flexure of the colon. Okay. This is your splenic flexure. This is your stomach. Okay. Now Ashi Shada beta देखो हम metastasis बोलते हैं if it is coming from some other organ ना. So these are coming from colorectal cancer. Usual cause of metastasis to the liver is colorectal cancer. HCC is the primary liver malignancy. ठीक है? Okay. Now let's go further. Okay. So there are two important cancers in the liver, metastasis or primary HCC. We have already seen them. Now let us try to look at some colonic problems. I want all of you to look at this barium meal follow through. This is your descending colon. This is your transverse colon. Okay. And this area is your cecum. This is your terminal ileum. This is your ileum. This is also ileum. Okay, beta. Okay. Anybody? Anybody wants to tell me? देख के बताओ. Where is the problem in this barium meal follow through? Okay. Now, okay, let me see. एक बच्चा कह रहा है sir, how will we differentiate between carcinoid and HCC based on the symptoms? If there is a carcinoid tumor which has gone to the liver, the patient would have the carcinoid syndrome that you might have studied earlier. Okay. Now, when we look at this particular case, the cecum is not normal. It is small, fibrosed, contracted. The ileum is also not normal. It is narrow stricture. It is narrow, fibrosed. So I'm saying cecum appears contracted and pulled up. Ileum is having stricture. So अब सोचो, why is the cecum contracted? Why is the ileum contracted? There must be fibrosis happening there, and fibrosis happens in chronic inflammatory disease. That means we are looking at a chronic inflammatory disease which involves ileocecal junction. Can anybody tell me which involves ileocecal junction? Anybody? Can you tell me? Ileocecal tuberculosis. Ileocecal tuberculosis. Okay, everybody? Now, so somebody saying, sir, ये barium colon में कैसे आ गया? बेटा, अगर आप orally, if you give barium orally, ultimately it will reach to colon also, na? But still, if you notice, you can see the dye in the small bowel. Dye is seen in enema. You will not see like this. I will show you enema also, but this is barium meal follow through showing you ileocecal tuberculosis. They will ask you in your exam, investigation of choice for bowel TB. What will you mark? Investigation of choice for bowel TB is CT enterography. Investigation of choice for bowel TB is CT enterography. Okay. And if they say investigation of choice for Crohn's disease, answer will remain the same, CT enterography. Investigation of choice for bowel TB as well as Crohn's disease is your CT enterography. Hey, bacha keh raha, sir, why it is not Crohn's and why the cecum is pulled up? Let me explain. Cecum is pulled up because of fibrosis. If you have a chronic inflammatory problem involving the ascending colon will become shortened, and fibrosis is pulling the cecum up. Cecum is pulled up because of fibrosis. BAMFT means barium meal follow through. Barium meal follow through. एक बच्चा पूछ रहा है, sir, why this is not Crohn's? देखो, Crohn's, whenever we see ileum and cecum both getting involved, ileocecal junction involvement is typical of TB. Crohn's can affect any part of the bowel. Crohn's can affect any part of the bowel, but ileocecal combination is very typical for TB. Whenever we see ileum and cecum both getting involved, so this is your cecum, conical, contracted, terminal ileum is narrow, so both of them are fibrosed. This is typical for tuberculosis. Okay. Now, एक बच्चा कह रहा है, sir, why this is not ulcerative colitis? This is not ulcerative colitis because ulcerative colitis will start in the rectum and then it will go to involve the entire colon. It will not be ileocecal. Okay. Now, let's try to understand another image. This is a barium enema image provided to you. Very unusual barium enema. In this enema, we can see the rectum, descending colon, transverse colon. The colon is all fibrous. Colon has fibrosis and it has become ahostral. Not only that, the dye has, the barium that we have given has refluxed into the small bowel. You have given via enema, but because in this patient the ileocecal valve is also fibrosed and incompetent, the barium has refluxed into the small bowel. So you can see there is incompetent fibrosed ileocecal valve. The entire colon is looking like a lead pipe. It is totally like a pipe. It is all fibrosed. Anybody now think of it? So whenever you see a fibrosed colon, a haustral colon, a pipe-like colon, always think of long-standing ulcerative colitis. Okay. One bacha is saying, sir, what is the investigation of choice for superior mesenteric artery syndrome? It will be a CT angiogram. CT angiogram. Okay. And ulcerative colitis will have a lead pipe colon. My question to you is this, beta. Anyone can answer, beta. Anyone can answer. Okay. What is the earliest X-ray feature or earliest barium feature of ulcerative colitis? Mucosal granularity. Okay. Everybody clear? Earliest barium feature of ulcerative colitis is mucosal granularity. Number two, please remember, ulcerative colitis other features are starts in the rectum, has contiguous involvement, disease is mucosal, can cause pseudopolyposis, okay, and usually the problem is colonic plus minus backwash ileitis is possible. Ulcerative colitis, earliest finding is mucosal granularity, starts in the rectum, contiguous involvement, mucosal involvement is there, pseudopolyposis might be there, involves colon plus minus backwash ileitis. Okay. Now one bacha is saying, sir, where is lead pipe colon? See beta, ये colon देखो, narrow हो गया ना Swati, can you see this has become narrow and there are no hostrae. So if the colon has fibrosis, it becomes like a pipe. There are no hostrae, the caliber reduces, that is what is called as lead pipe colon, seen in ulcerative colitis. Avirdan Bhaumik is saying, sir, why you are saying incompetent ileocecal valve? एक बार समझते हैं बेटा, देखो, if you give barium by enema, it should go into the cecum, but from cecum, how it can go into the small bowel? ये small bowel क्यों दिख रहा है? Because in ulcerative colitis, you develop fibrosis of the ileocecal valve, and because of fibrosis, it becomes incompetent, it stops working, and the barium is leaking into the small bowel. This is the same mechanism by which in pathology you might have read about that ulcerative colitis can involve the terminal ileum, where we call it as backwash ileitis. The ileocecal valve becomes incompetent. Okay, so this is your lead pipe colon. This entire thing is your lead pipe colon, beta. Everybody clear? Okay, let me zoom out. ना एक बच्चा कह रहा है सर असेंडिंग कोलन क्यों नहीं दिख रहा? मुस्कान बेटा, वो असेंडिंग कोलन में जो बेरियम था वही तो सारा रिफ्लक्स होके स्मॉल बाउल में चला गया ना, क्योंकि आइलोसिकल वॉल्व काम नहीं कर रहा. Okay, because the ileocecal valve is incompetent, the barium from the ascending colon has refluxed into the small bowel in this particular image. Now, let's go further. And let me ask you a question. If a patient who is a known case of ulcerative colitis presents to emergency with acute abdomen, okay, a patient who is, okay, this is your small intestine beta. You can see the complete folds. Okay. Now my question is, a patient who is having ulcerative colitis comes to emergency with acute abdomen, and the X-ray is shown to you, which shows a dilated transverse colon, which is dilated more than 6 centimeter with loss of hostrae. What will you call it? Anybody can answer this? बताओ. अल्सरेटिव कोलाइटिस है पेशेंट को, इमरजेंसी में आता है एक्यूट एब्डोमेन के साथ और ट्रांसवर्स कोलन डायलेटेड है. व्हाट विल यू कॉल इट? दिस इज कॉल्ड एज टॉक्सिक मेगाकोलन. दिस इज कॉल्ड एज टॉक्सिक मेगाकोलन. Okay. Now one bacha was saying, Shreya saying, sir, what is investigation of choice for bowel TB? CT enterography. CT enterography. A CT technique which has been optimized to look at the bowel. Same for Crohn's disease CT enterography. एक बच्चा कह रहा है सर आइलियोसिकल वॉल्व कैसे पता चला आपको कि इनकम्पिटेंट है? क्योंकि if the ileocecal valve is incompetent, that is why the enema, the barium was given through this route, enema, and it has gone into the small bowel. ए हॉस्ट्रल मतलब हॉस्ट्रे नहीं है, हॉस्ट्रे नहीं है बेटा सुधान, एब्सेंस ऑफ हॉस्ट्रे. Okay, this is the X-ray which this entire air-filled structure crossing the spine. This is your transverse colon. This is grossly dilated, more than 6 centimeter, and it has no hostray. This is what happens if it is a case of toxic megacolon. Okay, now let's go further and let us answer one more question. What will you find in a patient with Crohn's disease? Anybody? Crohn's disease में क्या मिलेगा? Crohn's disease can affect any part of the bowel. Involvement can be skip. You can have skip involvement also. Any part of the bowel can be involved. The involvement is transmural. While in ulcerative colitis the involvement was mucosal, in Crohn's disease the involvement is transmural. Crohn's disease is associated with perianal fistulas. Perianal fistulas are associated with Crohn's disease. Crohn's disease is also more involvement of mesenteric border of the bowel. Crohn's disease typically involves the mesenteric border in the bowel. Okay. Okay, everybody clear? Now, the question arises that how to identify it. I will show it to you. Now, it is very easy to see. Just give me 1 minute. I will explain to you and then we will look at one more question. This is your bowel loop which is involved. This bowel loop in CT scan has thick walls. If you notice, it has thick walls. But I want you to focus your attention on this fat. This is your mesenteric fat. This is your mesenteric fat. Please, without typing, look at this area. This is your normal fat of mesentery. On this area, it shows stranding. It is having line. It is stranded. Why? Because of increased vascularity. Why would you have increased number of vessels? If there is inflammation, hyperemia. This is what is called as comb sign on CT. Okay. So in Crohn's disease, the inflammation involves the mesenteric fat. It involves the mesenteric fat. So along the mesenteric border on CT, you will see a lot of blood vessels causing stranded appearance, which is called as comb sign, hair comb sign on CT, Crohn's disease. Ulcerative colitis is not a radiological diagnosis, so that is why I am not giving any IOC here. You will discuss about this in medicine. Ulcerative colitis in chronic stages you can see on a barium, but acute ulcerative colitis is not a radiological diagnosis. Okay, everybody understands? Are you clear? So Crohn's can affect any part of the bowel. Involvement can be skip, it can be transmural, perianal fistulas are seen, mesenteric border is involved with comb sign. My question to you is this, beta. Suppose in Crohn's disease you have, this is bowel, this is some area which is narrow, bowel narrowing. So this narrowing in Crohn's disease that happens because of fibrosis is called as string sign of Cantor. Narrowing that is happening, the strictures that happen in the bowel in Crohn's disease are called as string sign of Cantor. Because some part will be normal, some abnormal, some normal. This is skip lesion. It causes string sign of Cantor appearance. Okay, so what is skip lesion? Skip का मतलब क्या होता है? देखो, मैं I'll explain it to you. देखो, ulcerative colitis rectum से शुरू होके continuity में involve करता है. लेकिन Crohn's में some part of the bowel can be involved, some then there can be normal area, then there can be abnormal area. Crohn's disease, it is not necessary that the disease will be in continuity. Ulcerative colitis is a contiguous process. Okay, clear everybody? Everybody understands? Okay, now let's go further now. Crohn's disease can also affect the stomach. When it affects the stomach, it causes conical narrowing of the gastric antrum. When it affects the stomach, it causes conical narrowing of the gastric antrum, which is called as Ram's horn stomach. In which condition do you see Ram's horn stomach? Crohn's disease. Ram's horn stomach, Crohn's disease. Now, why is this image appearing white? Because this is a barium meal. This is a barium meal. Okay. Gulshan, what was COM sign? COM sign was, in Crohn's disease, you have increased vascularity on the mesenteric border because of inflammation in that area. That is called as COM sign. Okay, now let's see an answer question beta. Okay, anybody? Now let's see some miscellaneous questions. If you have a swollen epiglottis on the X-ray, it looks like this. Anybody can tell me what is the name of the sign? It looks like a thumb. So they are called as thumb sign on neck X-ray seen in acute epiglottitis. Thumb sign on neck X-ray is seen in acute epiglottitis. Okay. Here. Okay. So this is ram's horn beta. ये ram's horn इसको कहते हैं. And ram's horn stomach is seen in Crohn's disease. Okay. Now, if it is so easy, why do people get confused? Because there is another question saying thumb printing. Thumb printing means irregularity. Thumb printing of splenic flexure is seen in. Thumb printing of splenic flexure of colon is seen in. Now, splenic flexure is very important, which you will read later on in your surgery and anatomy also. Splenic flexure is the watershed area between the superior mesenteric artery and inferior mesenteric artery territory. Splenic flexure is the watershed area between superior and inferior mesenteric artery. So if you see irregularity or thumb printing in this area, you will call it ischemic colitis. Where do we see ischemic colitis? Splenic flexure. Appearance, thumb printing. And some more miscellaneous images. I want you to see these two images together. Anybody, can you tell me, this image has been asked in a previous NEET PG exam. Can anybody tell me what is the finding here? One loop of bowel is going into the another loop. What could this be? What could this be? This is called as the coiled spring appearance of intussusception. Coiled spring appearance of intussusception. And if you do a barium enema, how will you identify? If you do a barium enema, how will you identify intussusception? So the barium is going via the enema into the colon, but here the bowel is going in. So what is this? Anybody name the sign? Claw sign. And this is what I'm sure some of you might have seen in the last NEET exam. Claw sign on barium enema. This is the image intussusception. So these are the two possible images that they can show you. Coiled spring appearance, claw sign. Okay, these are signs of intussusception on a barium study. What else they can ask you in miscellaneous? This one. Anybody, what part of the colon is abnormal? What is this part? This is your sigmoid colon. What is it that you see here? Sigmoid colon has some outpouchings giving rise to a sawtooth appearance. Anybody can name the diagnosis now? Sawtooth appearance on a barium image. Anybody? Sawtooth appearance in a barium image. Anybody? So always think of diverticulosis. Sawtooth appearance, diverticulosis. But if they say investigation of choice for acute diverticulitis, Investigation of choice for acute diverticulitis. Okay, CECT. If they say acute diverticulitis, CECT. If they say diverticulosis, sawtooth appearance on barium enema. Okay, diverticulosis is seen on barium enema. Diverticulitis is seen in CECT. Okay, I think, and this was barium enema that many people were asking me. This is the claw sign of barium enema of intussusception. This is barium meal follow through, showing us a bowel going in within another bowel, that is coiled spring appearance. Okay, now anybody name the sign that I'm trying to tell you. This is called by caused by Clostridium difficile infection. Okay, I'm going very slow for Sahil Arora, very slow. These are very common things. You will read them multiple times in different subjects. Anybody can tell me now, in this condition, this is your dye, the colonic wall is swollen, the colon wall appears swollen, and it is compressing the dye into it, and it is giving rise to a appearance which is similar to this musical instrument. This musical instrument is accordion. This is accordion sign on CT. Okay. Now this accordion sign on CT happens if your large bowel or your colon is totally swollen. उसकी wall पूरी तरह सूज गई है, and the dye is compressed. So it looks like the folds of a accordion. This is seen in Clostridium difficile infection in pseudomembranous colitis. Only the name is important. I wanted you to understand the name. That is why I got the image. Accordion sign on CT, pseudomembranous colitis. Pseudomembranous colitis. And I think some of you might be tired, so let me offer you a coffee. In my previous class, I gave you coffee with milk because that was the first phase of the class. As we are coming towards the end of the radiology, tomorrow we will be ending it. I think you need some strong coffee. Let me give you some coffee bean appearance. Coffee bean appearance. Anybody, what is this? This entire structure that you see here, looking like a coffee bean, is nothing but your dilated, twisted sigmoid colon. Now in this patient, the sigmoid colon is again a mobile part of colon, has twisted on its own axis. If the sigmoid colon has twisted on its own axis, we will call it sigmoid volvulus. X-ray appearance, coffee bean sign. X-ray appearance, coffee bean sign. Okay. Now my question to you is this. If I do barium enema in this patient, what will happen? If I do barium enema in this patient, what will happen? If you give barium via enema, barium will go into the rectum. Then it will try to go into sigmoid, but it cannot go because there is volvulus, it will become narrow. If you do barium enema in a patient with sigmoid volvulus, you will see barium going into the rectum, and then it will become narrow at the site of volvulus. This appearance on barium enema is called as bird beak appearance, or we can say bird of prey sign. Bird beak appearance or bird of prey sign. So let me give you a MCQ to solve. All of you please answer this question now. Okay, and this will tell you what is happening in the exam. Beta, देखो मेरे साथ एक बार. Okay, in the NEET exam they gave a question. Bird beak appearance on barium enema is seen in achalasia cardia, CA esophagus, sigmoid volvulus, ulcerative colitis. Bird, okay, I'm repeating beta, Atul, don't worry, I'm repeating beta. देखो, bird beak appearance on barium enema is seen in achalasia cardia, CA esophagus, sigmoid volvulus, ulcerative colitis. Now, please try to understand the irony of medical education in India. Many children they went and marked ecclesia, है ना? वो कहते सर ने बताया था. Okay, can you understand? बहुत सारे बच्चे आए कहते सर सर्जरी में सर ने बताया था बर्ड वीक होगा तो एक्लेसिया होगा, बर्ड वीक होगा तो एक्लेसिया होगा, बर्ड वीक चिड़िया होगी, चिड़िया चिड़िया एक्लेसिया. हाँ, क्लियर? Understand? But nobody saw. It is very important. Many children did not see that they are saying enema. We know what is a enema. Dye is given, barium has been given through enema per rectal. So कितना भी जोर लगा लो, if you have given enema, it cannot reach the esophagus. कितना भी जोर लगा लो, you may put so much pressure, but still it cannot reach esophagus. The answer is sigmoid volvulus. You understand? What is this? What is this? This is how silly mistakes happen in exam. The examiner is saying enema. You are saying esophagus. Silly mistake. Okay. So what is bird beak? What is bird beak? Bird beak मतलब रेक्टम में बेरियम है क्योंकि इनिमा दिया, फिर वो नैरो हो गया, टेपर हो गया क्योंकि उसके आगे सिग्मॉइड कोलन ट्विस्ट होके वॉल्वुलस हो गया. क्लियर? Okay, some people are saying it is a hilarious question. What they are not understanding is when this happens in the exam, then the joke comes back on us. Okay, it is very important to be careful in the exam because एक क्वेश्चन गलत हो जाएगा फिर हंसी नहीं आएगी बेटा. ठीक है कि नहीं? Okay, let's go further now. What investigation do you think is this? Miscellaneous. This is a CT scan U of the colon giving us the inside view of the colon. That means with CT technology today, we can see inside the colon also. We can see any polyp is there or not. This is called as virtual colonoscopy. Okay. Virtual colonoscopy का मतलब कि we have not done a colonoscopy. We have not done a colonoscopy. We have done a CT scan. हमने CT scan किया है and with CT scan we are creating images which are looking like colonoscopy. है ना? इसको कहते हैं virtual colonoscopy. So question number 1, virtual colonoscopy is done with CT scan. Done for screening for colonic polyps. I'm sure you know in pathology you might have studied a disease called as familial adenomatosis polyposis, FAP. So in family members of patients with FAP, you want to do screening for colonic polyps with virtual colonoscopy. Okay, virtual colonoscopy is done with CT scan. It is not a colonoscopy, it is non-invasive. You have not put a colonoscope in his body. It is non-invasive, done using CT technology. Okay, coffee bean appearance Manoj Kumar was a X-ray sign of sigmoid volvulus. Okay, now let's go further now. So, you know, with this background, I think we can reach to the next topic, which will take us some time today, which is not a very long topic, small topic. What is the role of radiology in breast imaging? Because we have looked at the colonic problems and the bowel problems and I've tried to give you an overview, but what is the role of radiology in breast imaging? In breast imaging, you need to know about this investigation. Okay, anybody identify the investigation? Identify the investigation. Anybody? We are looking at mammography. What is this investigation? Mammography. How it has been done? How it has been done? This is the craniocaudal view, mediolateral oblique view. Okay, I am repeating beta. In mammography, two views are done, CC, MLO. Again, a very important MCQ. They will ask you, what X-rays are done in mammography? We do a craniocaudal view and a mediolateral oblique view. Okay, CC and MLO. Craniocaudal कैसे करते हैं? You compress the breast, keep the film below and rays are coming from the top. What is this? Craniocaudal view. Now second, you keep the film in the axilla, Compress the breast. Rays are coming from medial to lateral obliquely. What is this view? Medial lateral oblique. Okay, question number 1. What are two views done in mammography? Anybody? What are the two views done in mammography? Can you mark them? Craniocaudal, mediolateral, oblique. Out of these two, which one is the single best view? Or they might say maximum breast tissue is seen in which view? Out of these two, maximum breast tissue is seen with MLO. Maximum breast tissue is seen in MLO. This one is the MLO view, where you can see the axillary fold and the axillary part of the breast. So MLO, because you are keeping the film in the axilla, it also shows you the axillary part of the breast and also shows you the axillary tail. So always remember these two questions so far. Mammography, which are the two X-ray views? Craniocaudal, mediolateral oblique. Number 2, maximum breast tissue is included in mediolateral oblique. Very good, very good. I think a lot of you have already studied a little bit in surgery. Now tell me, why do we do mammography? Okay. Most important role of mammography is screening routine population for ductal carcinoma in situ breast. Mammography is done for screening routine population for ductal carcinoma in situ breast. Okay. Now, screening routine population. What do we mean by routine? All women more than 40 years of age should undergo annual mammogram to detect ductal carcinoma in situ. Okay. All women more than 40 years of age should undergo annual mammogram to look at ductal carcinoma in situ. This is routine screening. Okay. Now, how will you identify cancer? How will you identify ductal carcinoma in situ? Now, what happens is, if this is a duct in the breast, okay, when you have ductal carcinoma in situ, it develops chlamydionecrosis. Okay. If you have ductal carcinoma in situ, it develops chlamydionecrosis. In chlamydionecrosis, if you look at it morphologically, you will see calcification. In chlamydionecrosis, you will see calcification. Okay, let me answer a question by Dr. Pujali. Okay, sir, ये breast mirror image को लगा बेटा, ये दो अलग अलग breast है, right left ऐसे है ना. So we have 4 X-rays, one for each breast. Okay, now tell me. Okay, anybody? So in ductal carcinoma in situ, you would have chlamydionecrosis, which will develop calcium, which will develop calcification. अगर ये duct है बेटा, एक बात बताओ, इस duct में कैंसर हो गया, ductal carcinoma in situ हो गया, and it has chlamydionecrosis. So what will happen? You will develop calcification in it. And if I see that on a mammogram, this is how it will look like. What is it? You will be able to see micro calcification in a linear branching pattern. Most important sign of ductal carcinoma in situ on mammography is microcalcification in linear branching pattern. Okay, everybody understands? Everybody follows? Okay, so ductal carcinoma in situ breast में हमें क्या देखना है? हमें देखना है microcalcification जो linear branching हो, because the ducts are linear and branching. Everybody understands? Okay. On the other hand, if it is a benign condition, On the other hand, if it is a benign condition, it will look like this. What is this? Popcorn, or they can say macrocalcification. Popcorn calcifications or macrocalcification seen in benign condition like calcified fibroadenoma. Okay. If it is a benign condition, you will see popcorn or macrocalcification. If it is a cancer, you will see microcalcification. Okay, everybody clear? Now, let's make it more tough for you. Okay, I want you to spend a moment here. I want you to spend a moment here and tell me, look at this breast parenchyma. Look at the parenchyma here, parenchyma here. Can you see a difference between these two? Breast parenchyma in this patient and this patient. What is the difference? What is the difference? The difference is breast parenchyma in this particular case is appearing very dense. Why? Now we need to know, in young females on mammography the breast parenchyma appears dense because of glandular tissue. With age the glandular tissue reduces and the density reduces. So this must be a older female, this is a younger female, because the breast parenchyma appears dense. Any benefit of this? Any benefit of knowing this? So we know that young women have dense glandular tissue in the breast, so you can miss cancers on mammography. In a young lady, you might miss out on cancer on mammogram because the breast tissue is more dense, it is more glandular. Everybody understands this much? Are you able to understand the concept so far? Okay. Now what I will do is, I will give you a small table. Let's try to answer this question. And we will try to look at how to do breast cancer screening. How will we do breast cancer screening? Okay. First question beta, let's see if you can answer. Breast cancer screening. Routine population, 40 years of age. We need to do annual mammography. Okay. All women more than 40 years of age for breast cancer screening we do need to do a mammogram. Okay, not ultrasound beta, mammogram. Okay, गलत हो जाएगा. Second question, let's see if you can answer. If a woman has genetic high risk, that means the BRCA gene is positive, genetic risk, then how will you do breast cancer screening in a lady who has BRCA gene positive? These ladies should undergo screening MRI of the breast at 25 years of age. You should start doing annual MRI at 25 years of age, and you start doing mammography also for them at 30 years of age. If there is genetic risk, you will do MRI at 25 years of age, add mammography with at 30 years. Why MRI initially? Why not mammo? Because genetic risk patients can develop breast cancer at younger age group. In young females, mammography is not very sensitive to pick cancer because breast is dense. So that is why we are using MRI here. Third question is, if a patient has familial risk, family history of cancer, there is no genetic analysis available, only family history is there, then you will start annual mammography at 35 years of age. If there is a family history, you will start annual mammography at 35 years of age. It is all done annually. We have to follow the patient up every year. Everybody understands? So the age is different. Genetic risk 25, family history 35, no risk 40. Okay. Okay, MRI is also done annually. Clear? Now my question to you is this: can you for a moment look at another investigation here? Today we have a new variety of mammography which is shown to you here. In this investigation we can take cross sections of the breast. It is called as 3D mammography, or we use a word digital breast tomosynthesis, DBT. So what is this investigation? Digital breast tomosynthesis, also called as 3D mammography. What is the importance of this? If available, it should be preferred over mammography. Okay? That means if your hospital has digital breast tomosynthesis or 3D mammogram, this should be preferred over routine mammogram. This should be the preferred investigation. Okay, everybody understands? Okay, so this is little bit about mammography and the role in breast cancer screening. Let us make it more tough for you. What is the role of breast MRI? Anything that we need to know about breast MRI, and what should we know about breast ultrasound? Okay, what should we know about breast MRI and what should we know about breast ultrasound? Okay, first question. Breast MRI is done as a contrast enhanced MRI. First question, breast MRI is done as a contrast enhanced MRI. It is not plain, it is done with dye. It can detect ductal carcinoma in situ as ductal enhancement. I am repeating again, listen to me. Okay, एक बच्चा कह रहा है सर सीटी नहीं करेंगे. नहीं बेटा, सीटी स्कैन में तो रेडिएशन होती है, हमें उसको कैंसर कॉज थोड़ी करना है ना, हमें उसको ब्रेस्ट कैंसर की स्क्रीनिंग कर रहे हैं. वी वांट टू यूज इन्वेस्टिगेशंस व्हिच आर harmless like MRI, ultrasound, X-ray, mammogram, but not CT. CT has very high radiation. है ना? Now, anybody answer this question now? So, MRI of the breast cannot detect calcification. MRI पे calcification नहीं पता चलेगा. It is looking for ductal enhancement. That means the ducts which have cancer will pick up the dye because they will have some vascularity, and this is how you diagnose ductal carcinoma in situ on MRI. But there is a problem. False positive during menstruation. If you do a MRI during menstruation, the breast parenchyma is more vascular at that time and it enhances. So you might false diagnose at that time. That is why MRI, although it is sensitive investigation, it is sensitive for ductal carcinoma in situ, but not specific. It has false positive rate. Breast MRI should preferably be done in the second week of menstrual cycle. Why second week? To avoid false positive due to menstruation. It is the investigation of choice to evaluate breast implants. It is used to do screening for ductal carcinoma in situ in genetic risk group. It can differentiate scar from recurrence in the breast after operation. Okay. Now one बच्चा is saying sir mammogram भी तो एक्सरे है. Correct, mammogram भी एक्सरे है लेकिन उसमें रेडिएशन कम है, उतनी नहीं है जितनी सीटी में होती है. Okay. Okay, Brahmani, in BRCA gene positive after 30 years, we'll use both MRI and mammogram. Okay, anybody now answer these questions? Breast MRI is contrast enhanced MRI. It detects ductal carcinoma in situ because of ductal enhancement. False positive can happen during menstruation. It is sensitive investigation, not specific. MRI should be done in second week. It is investigation of choice for breast implants, investigation of choice for screening in genetic risk patients, scar versus recurrence. It can differentiate an operative scar from tumor recurrence. ऑपरेशन के बाद होने वाले स्कार को या उसमें कैंसर दोबारा हो गया उसको फर्क करने में ब्रेस्ट में काम आता है. स्कार वर्सेस रिकरेंस. क्लियर? अंडरस्टैंड? स्कार मतलब ऑपरेशन का निशान, रिकरेंस मतलब कैंसर का दोबारा हो जाना. Okay, now what about ultrasound? Breast ultrasound is indicated if you have a young female with breast lump. Investigation of choice is ultrasound. Young female with breast lump, investigation of choice, ultrasound. Solid versus cystic, ultrasound. Pregnant lady with a breast lump, ultrasound. A lactating lady where we are suspecting breast abscess, ultrasound. Okay. One bacha is saying, Dr. Hemram is saying, sir, kya MRI contraindicated hoga implant mein? Now, I want all of you to now listen to me very, very carefully. MRI is contraindicated if you have a metallic implant. Metal hota hai, magnet or metal mein interaction hota hai. In breast, you will not put metallic implant for obvious reasons. You will put silicone implant. So there is no contraindication. Okay. So don't do silly mistakes like this. Again, you will see silly mistakes will happen in the real exam if you don't think. You have to think. Don't ratify. Think. Okay. You will not put metallic implant in the breast. Clear? Now, everybody quickly answer beta. Breast, young female with breast lump, ultrasound. Solid versus cystic, ultrasound. Pregnant lady with a breast lump, ultrasound. Lactating female suspected breast abscess, ultrasound. Everybody understands? Are you clear, beta? Are you able to understand breast MRI, breast ultrasound? Now, how do we look at the implant? I will show you with the image. अभी some बच्चास आर लाफिंग बिकॉज दे थिंक कि दूसरों से गलती होती है. उन्हें नहीं पता कि हम आपसे भी हो सकती है, मुझसे भी हो सकती है. ध्यान से देखना पड़ेगा, तो गलती हो जाएगी. नाउ एवरीबडी, नाउ लुक एट दिस बेटा, लुक एट दिस. दिस इज अ ब्रेस्ट implant on MRI. This is a silicone breast implant on MRI. Is it normal or abnormal? Okay. Is it normal or abnormal? Please see. It is abnormal. Suppose this is a breast implant. Listen to me, everybody. Suppose this is a breast implant. Around the breast implant, body forms a capsule. Sometimes the implant ruptures. So two things can happen. Either it can be a intracapsular rupture or extracapsular rupture. Either it can be intracapsular rupture or extracapsular rupture. If it is intracapsular rupture, this is how it would look like. Okay, the implant will rupture but the capsule will be intact. Now I want you to see this image and understand the capsule is there but the implant is all irregular inside. It is ruptured. Implant has ruptured. So what is this? This is intracapsular breast implant rupture. This appearance looks like this. This is called as Linguini sign. On MRI. Linguini is a kind of pasta. So breast implant rupture can be intracapsular, extracapsular. Intracapsular rupture is the one which we can see with Linguini sign on MRI. Clear? And if you do an ultrasound, what will we see? On ultrasound, intracapsular rupture shows a step ladder pattern. Extracapsular rupture shows snowstorm appearance. Intracapsular rupture on ultrasound shows step ladder pattern. Extracapsular shows snowstorm pattern. Okay. Now, important thing is the terminology. Whenever we do a breast mammogram, MRI or ultrasound, the report is written in a format called as BIRADS. What is BIRADS? Anybody has heard of this before? What is BIRADS? Breast Imaging Reporting and Data System. What is BIRADS? Tell me. Breast Imaging Reporting and Data System. Okay. Now, before I tell you BIRADS, let me answer some doubts. एक बच्ची ने पूछा है सर अल्ट्रासाउंड लैक्टेटिंग फीमेल में क्यों यूज कर रहे हैं? देखो, when you will gradually, when you read surgery, you will realize lactation is during lactation, woman, if she develops a painful lump and fever, it could be an abscess. So abscess is very easily diagnosable. When you keep the ultrasound probe, you can diagnose it. It is very easy to diagnose. You do not do mammogram because mammogram requires compression. And if she has already inflammation abscess, if you compress, she will have a lot of pain. That is why in breast abscess, if it is suspected, we do ultrasound. Okay, beta? Mayuri, are you clear, beta? Okay. अगर कैप्सूल भी रप्चर हो गया तो हम बोलेंगे एक्स्ट्रा कैप्सुलर, अल्ट्रासाउंड में दिखेगा स्नोस्टॉर्म अपीयरेंस. इंट्रा कैप्सुलर पे अल्ट्रासाउंड में स्टेप लैडर पैटर्न. इंट्रा कैप्सुलर को एमआरआई पे लिंग्विनी साइन. ओके. एक्स्ट्रा कैप्सुलर के लिए कोई मतलब नाम नहीं है वहां पे, तो वी आर नॉट गोइंग इनटू इट. Okay, now let's see BIRADS. Have you done BIRADS in surgery so far or no? सर्जरी में पढ़ा था कि नहीं पढ़ा अभी? कोई बात नहीं, हम पढ़ लेते हैं. BIRADS में the categories are 0, 1, 2, 3, 4, 5, 6. 0 से 6 तक है. Okay? Okay, now let's see. What is BIRADS 0? BIRADS 0 report means that the radiologist is saying inadequate for opinion, that the mammography images that I am seeing are not enough for opinion. That is BIRADS 0. What is BIRADS 0? Tell me. Inadequate for opinion. Okay. Now anybody can tell me, if the mammography images are inadequate for opinion, what will be the management? 3 things. You can call the patient for ultrasound, compare with previous films, do a spot compression, of the suspected area. I am repeating. Okay, I am repeating. Okay, कल के लिए भी बहुत सामान है हमारे पास. कल हमें बहुत सारे फिजिक्स को पढ़ना है. So let's try to look at this again. If the patient has a BIRADS 0 report, that means it is inadequate for opinion. How will you do management? You will call the patient for ultrasound, compare with previous films, and you can do a spot compression film. You can compress the suspected area and do the mammogram again. Okay. Okay, now second question, beta. What is BIRADS 1? BIRADS 1 means negative. Absolutely normal mammogram will be called as BIRADS 1. What is BIRADS 2? Benign finding. BIRADS 1 means breast is totally normal. BIRADS 2 means there is a benign lesion in the breast, but definitely benign. Okay. एक बच्चा कह रहे कंप्रेशन क्यों करेंगे ज्योति? वी विल डू कंप्रेशन टू डिलीनिएट द डिजीज बेटर. Now, to see breast better in mammogram, we need to compress it. If some area is having more doubt, we can compress it even more and then clarify the doubt. Okay, so that is why if the Byrard 0 is there, you have a doubt, compress the doubtful area. Okay, now Byrad's 1 is negative, 2 is benign. Likelihood of cancer, 0% likelihood of cancer because mammogram is normal or benign. Management, continue routine screening. Nothing special, continue routine screening. Okay. Okay, after Byrad's, I will give you a break. Okay, what is Byrad's 3? Some children are wanting to eat pasta. So remember, what is Byrad's 3? Byrad's 3 means probably benign. That means if a radiologist is saying Byrad's 3, he is saying that most likely it is benign, but there is a small amount of doubt for cancer, which is classified as less than 2% likelihood of cancer. Management, short-term 6-month follow-up. Because the risk is very low, we don't go for biopsy, we go for 6-month follow-up. Instead of annually, you will do a short-term 6-month follow-up. Byrad's 4 means suspicious of malignancy. 5 means suggestive of malignancy. Byrad's 4 is suspicious of malignancy. 5 is suggestive of malignancy. Okay. Remember, suspicious means 2 to 95% likelihood of cancer. 2 to 95% likelihood of cancer. Suggestive means more than 95% likelihood of cancer. What do we need? Here the management is biopsy or tissue diagnosis is required because mammography is suggesting or suspicious of cancer. Byrad 6 is known case of biopsy proven malignancy. Byrad 6 is known case of biopsy proven malignancy. Byrad 4 is further divided into 4A, B, C. Okay, I will explain better. Give me 1 second. 4A is low suspicion. 4B is intermediate suspicion. 4C is high suspicion of malignancy. Now try to understand. We are doing mammography. I will just zoom it fully and come out of the screen so that you can see. We are doing mammography annually. So annually we are writing the report like this. If it is normal, I am saying Byrad's 1. If there is a benign lesion, I am saying Byrad's 2. If it is benign but some small doubt is there, I will say Byrad's 3, less than 2% likelihood of cancer. I will do 6-month follow-up. If it is suspicious, I will say 4. If it is highly suggestive, I will say 5. If biopsy is already done, then you will say Byrad's 6. Okay, this is what is called as Byrad's nomenclature. This is called as Byrad's nomenclature. Now Sahil is saying कि सर अगर biopsy होगी तो radiologist के पास भेजा क्यों? Very good question, Sahil. To look for multicentric lesions. देखो एक ब्रेस्ट में कैंसर था, आपने बायोप्सी कर ली, पता चल गया, फिर पता नहीं ना कि दूसरी ब्रेस्ट में भी ना हो. Okay, so we need to do a mammogram to see if there is any multicentricity, and if we see cancer is already reported on biopsy, we will call the report as Byrad 6. Okay, and this is how we write the report. This is the lexicon, the terminology to be used for mammography reporting. This is also used for breast MRI and breast ultrasound. We use Byrad's terminology only. Clear everybody? Okay. Now only a small topic is left. Maybe you can take a 10 minutes break or 15 minutes break. We will do PET scan today because we have to cover the surgical aspects today. After this I will teach you PET scan, and tomorrow we will look at the physics and radiotherapy together. Okay, tomorrow our goal will be physics and radiotherapy. Today our goal is to look at the PET scan after this. Okay, for ABC matlab low suspicion, intermediate suspicion, high suspicion. For A, B, C. Now we will look at the final topic of the day. This is a very important topic. Last year in the NEET PG they gave a direct visual from this topic. So that topic is PET scan. So anybody, it will take short time but high yield. 100% question from what I will teach. Okay, so just remember this. What is PET scan? PET scan full form is positron emission tomography. Anybody, what is PET scan? Positron emission tomography. Okay, everybody. Now I'll tell you some points, then I'll tell you the significance. What is the most common isotope used in PET scan? What is the most common isotope used in PET scan? Anybody? Fluorine 18. Most common isotope used in PET scan is fluorine 18. Half-life 110 minutes. Produced by a large machine which is not available everywhere called as cyclotron. Okay, I will revise for you better. Don't worry, I am revising for you. PET scan. Most common isotope used 18 fluorine. Most common isotope used 18 fluorine. Half-life 110 minutes. Very short, not very long. Generated by cyclotron. Okay. So how we are using it is very important to understand. Let us take a blank page. Let us take a blank page. Suppose you take 18 fluorine and you attach it to deoxyglucose. Can you tell me what is this? 18 fluorine deoxyglucose. What is this? FDG. So try to understand now. In FDG, the fluorine is the radioactive part, deoxyglucose is the carrier. So let us write one line over about it. What is FDG? It is a non-metabolizable glucose analog. So just now I told you, in PET scan the isotope which is most commonly used is 18 fluorine, okay Kruti and Parul, which has a half-life of 110 minutes and it is cyclotron generated. It is produced by cyclotron. This 18 fluorine, if it is attached to deoxyglucose, it is FDG, which is a non-metabolizable glucose analog. Okay, now let's try to understand. And the important question that we all need to answer is why PET scan is used in cancer patients. Let's try to understand. Suppose this is a cancer cell. Cancer cells take up glucose. Cancer cells for their energy need take up glucose. To take up glucose you need glut. You need glut on the surface. So cancer cells take up glucose through the glut and metabolize it with glycolysis. I am repeating. Cancer cells, they take up glucose through the glut transporters and metabolize it, burn it with glycolysis. The strange thing is, even if the environment is aerobic, still the cancer cell will undergo glycolysis. In a normal cell, in anaerobic environment you have glycolysis, aerobic you have Krebs cycle. But cancer cells, even if there is oxygen, if it is aerobic, still glycolysis happens. This is called as Warburg phenomena or Warburg effect. Okay, so I'm repeating. cancer cells undergo glycolysis, selective aerobic glycolysis, that is called as Warburg effect. Now my question to you is, I am sure we all know that glycolysis will produce less number of ATPs as compared to Krebs cycle. So ATP will be very less. So you need, if the energy is not being produced, you will take up more glucose. So cancer cell will have upregulation of GLUT transporters. They will have more GLUT on the surface. So important point to know is cancer cells have upregulation of GLUT. Through this GLUT, they can take up glucose. Now if I give FDG, what is FDG? It is a glucose analog. So FDG will also enter the cancer cell through the GLUT. And in the cancer cell, FDG undergoes phosphorylation. It becomes FDG 6-phosphate. In cancer cell, FDG undergoes phosphorylation to FDG 6-phosphate. Now this FDG 6-phosphate is a metabolic dead end. That means it cannot be metabolized. So FDG 6-phosphate is trapped in the cancer cell. So how we are using PET scan to look at the cancer? We are using FDG, which is a glucose analog. It is selectively taken up by the cancer cells because they have upregulation of GLUT. Why they have upregulation of GLUT? Because of the Warburg effect. FDG, when it is taken up by the cancer cells, it is phosphorylated into FDG 6-phosphate, which cannot be further metabolized. Okay, now tell me, now in your cancer, FDG 6-phosphate is concentrated. This FDG has 18 fluorine, which is radioactive. This 18 fluorine produces positrons. This 18 fluorine produces positron. Okay. What is positron? Anyone can tell me in the chat box. What is positron? Proton nahi bola, positron bola hai. Batao, what is positron? Positron is the mirror image particle of electron. It is a positively charged electron. Okay. It is a positively charged electron. Okay. Now see what will happen. So suppose this is a PET scan machine. Let's try to understand. Suppose this is a PET scan machine and this is your patient. He has cancer. In the cancer you have fluorine accumulating. Now the fluorine will produce positrons. It will emit positron. What is positron? It is a positively charged electron. Now in your school, did they teach you matter and antimatter cannot exist together? They will destroy each other. So as soon as positron comes out, it meets an electron in the normal world. It meets an electron it meets an electron there. What will happen? So whenever an electron and positron meet, they cause annihilation. They are destroyed. But you know from your school physics that mass cannot be destroyed. It gets converted into energy. So as a result, 2 gamma photons are produced. As a result, 2 gamma photons are produced, which will go exactly opposite direction with energy 511 kilo electron volt each. These gamma photons, when they strike our PET machine, when they strike the machine, we are able to detect the signal. Okay, are you able to understand this? What is happening in the PET scan? In PET scan, we are using an isotope called as 18 fluorine, which is emitting positrons. When the positron is emitted, it meets an electron to get annihilated. As a result, 2 gamma photons are produced. They will go exactly opposite to each other to cancel the momentum. Each of them will have an energy of 511 kilo electron volt each, and then when they strike the machine, we are able to detect it. So that means PET scan machine is detecting a dual photon peak. That means when the two photons strike the machine, signal is generated. Are you able to understand what is happening in the PET scan? So far I'm going to repeat it again. So far what I have said is, I told you PET is slightly complicated but very interesting. PET scan is based on an isotope called as 18 fluorine produced by cyclotron, which is a very large nuclear reactor not available everywhere. It is a particle accelerator. So 18 fluorine produced by cyclotron, half-life 110 minutes. Okay, now tell me, 18 fluorine attached to deoxyglucose. Okay, so it becomes a glucose analog. 18 FDG. FDG is fluorodeoxyglucose. FDG will be taken up by the cancer cells because they have upregulation of GLUT. Why do they have upregulation of GLUT? Because they have inefficient metabolic pathway called as Warburg effect. When the cancer is accumulating FDG, it will accumulate fluorine. In the PET machine, fluorine will keep emitting positrons, which will get annihilated by meeting an electron to produce two gamma photons, which will go exact opposite to each other to cancel the momentum. When both the photons strike the machine, that is called as a dual photon peak, a signal is generated and we are able to see that there is a isotope being concentrated in an organ. Okay, interesting. This is definitely, each of them can be asked as a MCQ. Okay, very interesting, and that is why I told you it's very interesting from physics point of view, also biochemistry point of view also. Now see clinical point of view. Why do you need a PET scan? The advantage is that because it can see the cancer, because cancer is also based on glucose metabolism, PET scan is based on glucose metabolism, so it helps you to stage the cancer. In lung cancer, lymphoma, you will do staging with cancer, where it can tell you where all the cancer is present and you can do staging. It can also be done, it can also be used to assess response to therapy. That means after you give chemotherapy to a patient, you can see by doing a PET scan if there is any reduction in metabolism or not. Classically, if you follow up a cancer with CT, you can only see size reduction, but with PET we can also see metabolism, so you can see response to therapy. You can also differentiate a scar from recurrence, except breast. In breast, scar and recurrence is differentiated by MRI. Other body parts, if you have done a surgery and at the surgical site a tumor is recurring, you will do a PET scan to diagnose. Okay. It can also help you to assess myocardial viability. If a myocardial tissue is alive or not, you can see on a PET scan. It can also help you to assess solitary pulmonary nodule. Okay, this is what we will talk about, but these are the uses of PET scan. I'm repeating: staging of cancer, assess response to cancer therapy, to differentiate an operative scar from tumor recurrence. It is obvious that the scar will have low metabolism, cancer will have high metabolism. To assess myocardial viability, to assess a solitary pulmonary nodule. Okay. Jyoti, in breast, I told you, Jyoti Haldmani, I told you in breast for scar versus recurrence, we use a MRI. So if you remember, we have written there, MRI is the investigation of choice. Okay. In breast, here MRI is useful. Okay. Nida, correct. Okay. Now, let's go further. So, can you have a false positive with a PET scan? Can you have a false positive with a FDG PET scan? Answer is yes. Many times inflammatory conditions like tuberculosis can also show FDG uptake. Many times inflammatory conditions like TB can also take up FDG and become confuser for cancer. ओके बच्चा इसके सर नॉर्मल सेल एफडीजी लेगा. देखो एक बार समझते हैं उर्मी पोपटानी प्लीज सी देयर आर टू सेल्स one is cancer cell one is normal cell which will take up FDG cancer cell. Why? Because it has more GLUT transporters. Okay, so inflammatory tissue can be a confuser. Sometimes tuberculosis acts as a cancer mimic on PET scan. It acts like a false positive. Second false positive is physiological. Physiologically, in infants and in supraclavicular area in the adult, we have a tissue called as brown fat. What is brown fat? Metabolically active fat, which is heat producing fat. Okay, let me again tell you, in infants you have brown fat. In adult it is not there but left behind in some areas like supraclavicular area. So supraclavicular area in adult has brown fat. Brown fat is metabolically active. So if it is metabolically active, it will show high uptake of FDG. Again, if you don't know this, you might get confused between cancer. So it is a cause of false positive. Okay, it is FDG beta. I said FDG. Okay, Goku Tiwari, FDG, fluorodeoxyglucose. Okay, FDG कैंसर में काम आता है, but it can be false positive in inflammatory conditions like tuberculosis, and brown fat is also a source of error. Physiologically, brown fat also uptakes FDG in the supraclavicular area in the adult. Okay, the isotope that is attached to deoxyglucose is fluorine 18 beta. Manoj Kumar. Okay, now can you have false negative also? False negative मतलब कैंसर है लेकिन पेट पे नहीं दिख रहा. Is it possible to have a false negative? False negative means that there is cancer but PET is unable to see. It is possible to have false negative if you have low metabolic rate tumors. Can you name any low metabolic rate tumor? Carcinoid, bronchoalveolar carcinoma. Low metabolic rate tumors like carcinoid, like bronchoalveolar carcinoma can be missed on a PET scan. Can be missed on a FDG PET scan. Now you can see now this is the depth in which the central exams go. In one of the AIMS exams they have asked which cancer can be missed on FDG PET scan. The answer was carcinoid. Okay. So whenever I am teaching you might think ये तो नहीं पूछेंगे, ऐसा नहीं है. If I am teaching it is likely to be asked. Okay. False negative carcinoid, bronchoalveolar cancer can be false negative. And let us try to understand one more false negative with an image. Now this time they had given an image like this in the NEET PG exam. What is this image? Let's try to understand first the logic, then I will tell you the finding. This is a normal CT scan of the body. The first image is a CT scan of the body. Second image is a PET scan of the body. Okay, I will tell you pulmonary nodule. Beta, please wait and please see. Now please see this image, very important, last year's NEET PG question, directly from our image book. Please see with me, beta. And you can now appreciate that, you know, why we are able to predict, because we are going clinically. I am looking at every investigation. This is a CT scan. This is a PET scan. Nowadays, what we do is our machine is able to fuse these two images. We are able to fuse them. If I fuse them, it creates an image like this. What is this image? This is a PET CT. This here NEET PG question. This is a PET CT. Are you able to identify? Okay. Now, very rightly Jitendra Tyal is saying कि sir brain को देखो इसके brain को देखो. Can you see brain is also taking up so much glucose? Brain is also taking so much glucose. आप समझ आया पढ़ाई के समय भूख क्यों लग रही है? Brain is also taking up so much FDG. Yes? That is physiological. Physiologically, our brain parenchyma takes up FDG. That is a physiological thing. Okay. Now tell me. I am going to give you a interesting MCQ to solve. Assertion. Small brain tumors can be missed on a FDG PET scan. Okay, I'm making a statement now. I'm saying small brain tumors can be missed on a PET scan. Assertion. True या false? बताओ. कोई छोटा सा ब्रेन ट्यूमर होगा ना पेट पे मिस हो जाएगा. क्यों? True या false? Answer is true. This is true. We can miss small brain tumors. True. Why? Reason क्या है? You can see this MBBS AIMS exam pattern. Can you see assertion reasoning pattern? Yes. Now see assertion reasoning. Reason is because of high uptake in the normal brain. Normal brain is showing so much FDG uptake that the tumor is hidden inside. So brain tumors, brain metastasis can be some, if it is very small, you can miss it on PET scan. Brain metastasis can be missed on FDG PET scan. Always remember, because of high metabolic rate in the brain, like Jitendra Tyal in our class already picked it up कि brain में बहुत uptake हो रहा है. So इसके अंदर tumor भी होता तो छोटा सा होता तो miss हो जाता. Are you clear बेटा? Okay. I will also talk about heart also beta. Just give me 1 second. I want you to see one more image. देखो पहला इमेज सीटी है, दूसरा पेट सीटी है. देखो क्या दिख रहा है, देखो दूसरा पेट है. देखो on the CT scan we can see lung has a nodule. On the CT scan we are able to see lung has a nodule. Suppose you do a CT scan and you discover a nodule in the lung. So either it is a benign nodule or a cancer, we don't know. So we need to evaluate this solitary pulmonary nodule further. एक अकेला lung nodule है और कुछ है ही नहीं. There is just a solitary pulmonary nodule and I don't know, I might have picked up a early malignancy. How will I evaluate solitary pulmonary nodule? I will do a PET scan. If you do PET scan, now see in this patient, what do you see? Nodule is showing high uptake, high metabolism. That means it is a cancer. We should do a biopsy. That is why I said investigation of choice for solitary pulmonary nodule is PET scan. Because if you see a single nodule in the lung, to characterize it, we need to do a PET scan before we go for a biopsy, because biopsy will be invasive. So first we do PET scan. If it is metabolically active, you might think of doing a PET scan. Bacha Mongia is saying investigation of choice for brain metastasis. Investigation of choice for brain metastasis is contrast enhanced MRI. It is not PET scan. Clear? Everybody understands? So what is PET CT? A fusion of PET and CT images together is called as PET CT. Okay. So you can see the first image is a CT, second is a PET scan. Okay. If we fuse, we will create an image something like this. This is the kind of image which you had. You could see white bones as well as metabolic activity. This is a CT and PET fused image. Okay. Now, my question to you is this. Let's try to solve more questions. Okay. What is myocardial viability that I talked about? Okay. I will explain. Just give me 1 second. Now, what happens in heart is Suppose if this is the myocardium, suppose I do echocardiography in this patient and I find that this part of the heart is not contracting, it is akinetic. Okay. The other bright spot that we were seeing were in the urinary tract. The isotope was getting excreted. Just ignore them. Just listen to me here. Sometimes when we do a echocardiogram, we find that a part of the heart is akinetic. It is not contracting. What could it be? What could it be? Anybody? What could it be? It could be a myocardial scar. Scar is non-viable, dead. Any other possibility? Any other cause of a akinetic segment in the heart? It could be a hibernating myocardium. What is hibernating myocardium? Anybody knows? Hibernating myocardium is chronically ischemic myocardium which is viable but akinetic. ओके अब दो बातें हो सकती हैं. अगर इको पे हार्ट में कोई एरिया कॉन्ट्रैक्ट नहीं कर रहा, या तो वो स्कार है, डेड है, या वो हाइबरनेटिंग है. हाइबरनेटिंग मतलब क्रॉनिक इस्कीमिया है, जिंदा है लेकिन कॉन्ट्रैक्ट नहीं हो रहा. ओके, आई एम अगेन रिपीटिंग इन इंग्लिश. स्कार is a dead tissue which is not contracting. Hibernating myocardium is chronic ischemia which is alive but not contracting. So how will you differentiate? We will do a PET scan. Non-viable tissue, FDG uptake negative. Dead tissue में FDG uptake ही नहीं होगा. Hibernating myocardium में FDG uptake normal से भी ज्यादा होगा. I am repeating and I will ask you, okay, listen to me, very important question I will ask you, but listen to me and answer. If it is a myocardial scar, there will be no FDG uptake. But if it is hibernating, there will be high FDG uptake, very high FDG uptake. Anybody tell me why? Normal से भी ज़्यादा क्यों? Why more than the normal? Because normal myocardium is utilizing fatty acid metabolism. Ischemia is using glucose metabolism. So hibernating myocardium, because it is ischemic, has higher FDG uptake even more than the normal myocardium. Okay, do you remember this or not? Did you read this in biochemistry? That normal myocardium utilizes fatty acids for metabolism, while hibernating myocardium, because it is ischemic myocardium uses glucose. Okay. Everybody follows? Now, if we go further and I ask you 2-3 more questions, what are new updates? New updates are, today we have something called as sodium fluoride PET. Today we have more isotopes available. Instead of FDG, we can use sodium fluoride. Sodium fluoride is used for bone metastasis. For example, for pure lytic metastasis. For pure lytic metastasis, sodium fluoride PET is better than a bone scan. And if you remember, we talked about in my last class also that bone scan is, the drawback is it misses pure lytic metastasis, for which we can use sodium fluoride PET. Okay. There is something called a C11 methionine PET. It is based on amino acid metabolism. And it, if available, it is used for brain tumors. That means, okay, that means that today, okay, today we have more isotopes available other than FDG. We can use sodium fluoride for bone, C11 methionine for brain. Now, another question. Now anybody can answer why PET scan is not available in many cities. Okay, anybody can answer this question. Why PET scan is not available in some cities? Anybody? Why? Because to do a PET scan we need a cyclotron nearby, and cyclotron facility is not available in every city. That is why. Okay, it is not just the money, it is the cyclotron which should be available nearby. Okay, cyclotron is the limiting factor. So it is logical now that in future we should be creating non-cyclotron PET isotopes, and one of the non-cyclotron PET isotopes which is already being used is gallium 68. Gallium 68. How it is used? Let me explain to you. Gallium 68 is a non-cyclotron PET isotope. If you bind it to DOTA-TAT or DOTA-TOC, can you tell me where it is used? ओके संस्कृति ज्योति एंड अमृत पूनम कह रहे साइक्लोट्रॉन क्या होता है? साइक्लोट्रॉन एक पार्टिकल एक्सेलरेटर होता है. आपने स्कूल में फिजिक्स में पढ़ा होगा, हाई स्पीड पे पार्टिकल को एक्सेलरेट करता है. ओके, इट इज अ पार्टिकल एक्सेलरेटर. नाउ एनीबडी? सो अनमोल त्यागी कह रहा है C11 मिथ्योनिन पेट विल बी बेटर देन FDG पेट फॉर ब्रेन ट्यूमर. यस. ओके, साइक्लोट्रॉन इज पार्टिकल एक्सेलरेटर. स्कूल में याद करके पढ़ रहे थे कि समझ के पढ़ रहे थे? ओके, नाउ टेल मी. सो इफ आई एड गैलियम 68 टू DOTA-TAT or DOTA-TOC, this PET scan was asked in a previous Central Institute paper. Can you tell me where is this used? This is now recommended for neuroendocrine tumor diagnosis. Neuroendocrine tumors. Okay, very good, Muskan. Very good. Neuroendocrine tumors, we will use gallium 68, DOTA-TAT, DOTA-TOC PET. Gallium 68 PSMA PET. Again, a possible AIMS question. PSMA is prostate specific membrane antigen. Prostate specific membrane antigen. So gallium 68 PSMA PET is used for obviously prostate cancers. Okay, C11 methionine PET is used in brain tumor beta. Dr. Lahiri, brain tumor. Okay. Gallium 68 PSMA, prostate tumors. Gallium 68 DOTA-TAT for neuroendocrine tumors. Now, if we correlate, I will try to correlate with you one interesting fact, which will be last fact of the class. There is a new isotope available called as lutetium-177. It is a strong beta emitter, weak gamma emitter. Now these beta rays have a property that they can kill the tumor. Beta rays have the property that they kill the tumor. Beta rays kill the tumor, kill. Now suppose you take lutetium and bind it to DOTA-TAT. Can you tell me what will it do? Okay, let's see if you can understand. This is a new kind of targeted therapy. DOTA-TAT is a ligand which will go to the neuroendocrine tumors. DOTA-TAT is a ligand which will localize in the neuroendocrine tumor. Lutetium is a beta emitter. Beta rays kill the tumor. So what is this? This is a new therapy called as PRRT. This is peptide receptor radionuclide therapy used in neuroendocrine tumors. Peptide receptor radionuclide therapy used for neuroendocrine tumors. Okay, now, so one question that I see repeatedly in the chat box is this. Now try to understand this image. This will be clear. If you see a orangish color and white bones, okay, this is a PET CT image. This is a PET CT image. This is a pure CT. This is a pure PET. This is the fused image. And this was the one that was asked in the exam last year. Okay. Okay. So let us, okay, just give me 1 second. Let me go back to the PRRT. PRRT, Shweta Yadav, don't worry. We will do it again only for you. What is PRRT? Let us find out. Okay. So lutetium dotatat therapy is called as PRRT, which is peptide receptor radionuclide therapy. It is used to treat for treatment of neuroendocrine tumors. Used for treatment of neuroendocrine tumor. Lutetium is a special isotope. It is not used in PET scan. It is a therapy isotope. It is a therapy isotope, beta. Harika is saying, can we use C11 methionine PET for brain tumors? Yes, we can use it, but it is not commonly available. So that is why I said contrast MRI is the IOC for brain metastasis. Okay. Nandini is saying low metabolic rate tumor bata do. Low metabolic rate tumors are carcinoid and bronchoalveolar cancer are low metabolic rate. They are missed on FDG PET. Okay. Gallium 68 is non-cyclotron isotope. Yes, correct, Kamran. ओके लुटीशियम साइक्लोट्रॉन वाला नहीं है, ये लुटीशियम एक थेरेपी आइसोटोप है. लुटीशियम इज नॉट रिलेटेड टू पेट स्कैन, लेकिन मैंने आपको लॉजिक दिखाया कैसे हम पेट स्कैन से मैं आपको थेरेपी भी सिखा पा रहा हूं. ओके दिस इज लुटीशियम लुटीशियम 177. इट्स अ स्ट्रॉन्ग बीटा एमिटर, वीक गामा. द बीटा रेज विल किल द ट्यूमर. ओके एंड क्षितिज इज सेइंग कि अगर लुटीशियम को पीएसएमए से बाइंड कर दो. क्षितिज इज सेइंग सर लुटीशियम को पीएसएमए से बाइंड कर दो. बिल्कुल ठीक बात है. इट इज ऑल्सो वन ऑफ द एक्सपेरिमेंटल थेरेपी फॉर प्रोस्टेटिक मेलिग्नेंसीज. इट कैन बी यूज फॉर प्रोस्टेट कैंसर बट एक्सपेरिमेंटल इट इज देयर. गुड ऑब्जर्वेशन बेटा. Okay, so it depends on the ligand. What ligand we are using will tell us where it is going. Tomorrow in my class I will talk about other isotopes that can be used for cancer, like radioactive iodine, radioactive phosphorus. We will talk about the isotopes tomorrow. Okay, and we will also talk about the thyroid scan also tomorrow. So now what we will do is, as is customary to go, we will try now to look at the rapid fire quiz. So this is where I think you were yesterday. We were at this question. Remember, yesterday we were at this question. Anybody, can you answer now? Dota tat. Okay, let me answer some questions. Om Ashwin and Gokul Raj. Dota tat is a ligand which binds to the neuroendocrine tumor. Okay, now tell me, everybody answer. Osteogenesis imperfecta, all are true except, answer is metaphyseal fractures, because metaphyseal fractures are seen in child abuse. Diaphyseal fractures are seen in osteogenesis imperfecta. Correct? Everybody got it right yesterday? Okay. Now answer this question now. A clinical vignette for you today. 33-year-old man has swelling in the tibia, multiple demarcated lesions. Microscopic examination has epithelial cells, fibrostroma. What could it be? Tibia में वो कौन सा ट्यूमर हो सकता है? Anybody can answer. Which tumor can you have in the tibia which could have epithelial cells, anterior shaft of tibia? Let us see the choices. Can you now remember from the classes? Can you remember from the classes? Which tibial tumor? Which tumor in the tibia has epithelial cells? What is your answer? Adamentinoma. adamantinoma, anterior cortex of tibia, and has epithelial cells. So this is how they frame the question based on what I have already taught you in the class. Okay, everybody, can you see now you are able to answer a top level question? This is not an easy question, but you are able to do it. Which of the following usually produces osteoblastic secondaries? Which of the following usually produces osteoblastic secondaries? Anybody? What is the most important cause of osteoblastic secondaries? Anybody? Osteoblastic secondaries? Anybody? What could be the answer? CA prostate. The answer will be CA prostate. Cancer prostate is a classic cause of osteoblastic metastasis. And which cancer causes expansile metastasis? Which cancer causes expansile metastasis? So I told you that the metastasis from kidney and follicular cancer of thyroid are very vascular. So they are pulsatile, they expand the bone. What is your answer? Kidney. Kidney and thyroid are metastases which are expansile. They are very, very vascular. They, because of the pulsation, they expand the bone. Okay, always remember expansile metastases are seen in thyroid and kidney. In thyroid, follicular cancer thyroid. Okay, so let's see some more questions. Some more questions for today. Okay, let's hope for the light to be thankful to us. Now quickly tell me, ultrasound machine principle is, what is the principle of ultrasound machine? Anybody? Piezoelectric effect. Piezoelectric effect. Yes, did we discuss this? Piezoelectric effect. Most important investigation for posterior urethral valve is PUV, investigation of choice for posterior urethral valve. If anybody can recall, MCU, MCU. Remember, vesico-ureteric reflux and posterior urethral valve, MCU is the answer, MCU. What is this cystographic appearance? Anybody now? This is something that I had taught you, but I did not show you the image. Now I am showing you the image. What is this? Christmas tree like bladder. Christmas tree like bladder. What could be the answer? What could be the answer? This is neurogenic bladder. Christmas tree bladder, neurogenic bladder. This is Christmas tree bladder, also called as the neurogenic bladder. Neurogenic bladder. Bosnack classification is used for. Anybody? Bosnack classification is used for. Anybody can recall? कहां पे बताया था? Renal cysts. Remember I taught you renal cyst में Bosnack classification होती type 1, 2, ignore, 3, 4 could be cancer. Yes? Okay. Investigation of choice to demonstrate vesico-ureteric reflux. Investigation of choice to demonstrate VUR. VUR. Anybody? MCU. MCU. Investigation of choice for VUR is MCU. Micturating cystourethrogram. Widening of C-loop of duodenum is seen in. Widening of C-loop of duodenum is seen in. What is the answer? Cancer, head of pancreas. Widening of C-loop of duodenum is seen in cancer, head of pancreas. CA, head of pancreas. Clear? Coiled spring appearance. Coiled spring appearance on barium. Anybody? Coiled spring appearance कहाँ पे बताया था मैंने? Coiled spring appearance. Intussusception. Intussusception. Coiled spring appearance was seen in intussusception. Intussusception. Investigation of choice for acute pancreatitis. Investigation of choice for acute pancreatitis. Anybody? What was the answer? Acute pancreatitis का क्या आंसर था? CECT, contrast enhanced CT. Acute pancreatitis investigation of choice, contrast enhanced CT, contrast enhanced CT. I can see you are actually going to burn your phone now. Okay, clinical vignette now. So you can see I have mixed the question. Yes, last class I had shown you more visuals. Today I am showing you more clinical questions. 55-year-old patient has jaundice, weight loss, CBD is dilated, pancreatic duct is also dilated. Anybody wants to tell me? Anybody? जॉन्डिस है, वेट लॉस है, तो कुछ कैंसर हो सकता है. लेकिन बाइल डक्ट भी डायलेटेड है, पैंक्रियाटिक डक्ट भी डायलेटेड है. दैट मीन्स वी आर डीलिंग विद the double duct sign. Both the ducts are dilated. That means the tumor is at the junction of the ducts, which is the ampulla. The answer is periampullary cancer. The answer is periampullary carcinoma. Are you able to apply now? That whatever we have learned how to apply in MCQs is what I'm trying to teach you. Investigation of choice for CHPS. Investigation of choice for CHPS. Anybody can answer now. Congenital hypertrophic pyloric stenosis. Every time answer ultrasound, ultrasound, ultrasound. CHPS ultrasound. Clear? CHPS investigation of choice. Ultrasound, ultrasound. Everybody answers. So you can see now that we have done some extra, things with you, some extra notes, some extra coverage. So now what I will do is I will end the class today with a positive note like we every time do. Today I will tell you the secret. The secret is many people dream of doing big things in life. है ना, यहाँ पे आसान है, यहाँ तक आसान है, ठीक है. Many people dream of doing big things in life. That is easy. Many people would dream. But then what happens? Many people, as soon as they dream, they become afraid of their own dream. Okay, and they find fears. एम्स में तो नहीं हो पाएगा यार, किसी का भी नहीं होता है. They get afraid of their own dream. ओ यार नहीं हो पाएगा यार, नहीं हो ही नहीं सकेगा. Okay, they become so much afraid. नहीं नहीं यार, एम्स तो बड़े किसी और का होता है, मेरा नहीं हो सकता. You can understand. ओ यार नहीं यार, मैं नहीं कर पाऊंगा. So they become afraid of their own dream. Now what will happen? Because of fear, they give up. They don't do anything about their dreams. They give up and they end up having regrets. So first barrier to break in life is break the barrier of fear. डर हटाओ. Be fearless. अगर सोचा है कि जीतना है तो जीतना है. Okay. So बच्चा कह रहा है सर what textbook to read? Only read what I am teaching you बेटा. Okay. Now second question. Some people are able to break the barrier of fear. So after fear what happens? If you break your barrier, now you start to work. When you start to do hard work. So what happens when you do hard work? When you do hard work, you have pain. This is pain of hard work. अब क्या होता है, कई लोग काम शुरू करते हैं, सपना देखा, काम भी शुरू कर दिया. Some people they dream and they start working, but when they work, it is pain. नहीं हो रहा यार, रात हो गई, पढ़ाए जा रहे हैं यार, इतनी लेट हो गया, पढ़ रहे हैं यार, ऐसे थोड़ी होता है, हमने खाना नहीं खाया, ऐसे थोड़ी होता है. You understand? So people will start complaining. सर इतना मेहनत तो नहीं कर सकते. आई कीप मीटिंग पीपल हु विल से सर यार मैं भी करना चाहता हूँ काम, लेकिन यार तेरी तरह 11 बजे तक काम नहीं करूंगा. यू अंडरस्टैंड? सो मेनी पीपल व्हाट हैपेंस इज बिकॉज ऑफ द पेन ऑफ हार्ड वर्क गिव अप. व्हेन दे गिव अप, नाउ व्हाट हैपेंस? रिग्रेट्स. Okay, if you give up, what will happen? Regrets. Now this regrets is very important. If you have regret, what will happen? यार काश मैं डरा नहीं होता, काश मैंने छोड़ा ना होता. You would have worked harder but you gave up. So what happens when you have regrets? You change as a person. You change as a person and you become someone who you do not want to become. Have you ever seen in your college, sometimes you might have met some professor. Sometimes I meet a college professor जो मिलते ही बोलता है सारे बच्चों को फेल करूंगा. Have you ever met a professor in your college who says I will fail everybody? What is this? Why would he fail everybody? It is not to do with you. It is to do with regrets in life. If you have regrets in life, you change as a person. You become somebody negative. You say इसको भी निकालो, उसको भी fail कर दो, उसको निकाल दो. You become negative. So regrets are the worst poison to accumulate in your system, because if you have regrets, you change as a person. So do not give up because of fear or pain. But if you continue forward, despite the barriers of fear and pain, you continue forward. You bring enthusiasm to the table. And you enjoy what you are doing, you enjoy the journey. Now what will happen? If you are enjoying your studying process, if you are enjoying your journey with enthusiasm, what will happen? Tell me. Entire universe will help you. सब कुछ ठीक होना शुरू हो जाएगा. जो भी आज गलत हो रहा है ना, सब ठीक होना शुरू हो जाएगा. अब अभी लग रहा है ना सभी मेरे खिलाफ है, ऐसा नहीं, कभी कभी लगता, I keep meeting students who will say, sir, family is also not supporting, college is also not supporting, government is also not supporting, country is also not supporting, what to do? But if you break the barrier of fear and pain, bring enthusiasm and you bring joy to the journey, मेहनत करेंगे, मस्त होके पढ़ेंगे, है ना, मेहनत के साथ, you will see everybody will help you, entire universe will help you. This is how I have seen it happen in my own life, and I'm sure it is going to help happen in your life also. I wish you all the best. God bless you. I look forward to interacting with you on various social media platforms, including Instagram, and it is my pleasure to interact with you. कोई भी कुछ चीज होगी, I am more than happy to answer your queries. Tomorrow again 5 o'clock. We will end the class tomorrow with the radiation physics and the miscellaneous topics of radiology. I've already covered the entire clinical things for you. Tomorrow I will cover the nuclear scan, thyroid scan, radiotherapy, brachytherapy, all those miscellaneous topics. So please be there tomorrow at 5 o'clock. It is an important topic, and then we will finish the radiology. I wish you all the best. Good night.